Yes, we are all set to have our next session on dermatology. And I hope with every passing day and every passing session, all of you out there are getting academically wiser. And yes, let us all remember that apna time apun khud laega. Welcome once again, all of you in the India's biggest Med PG Prep academic event, the DAMS Visual Treat, often called as DVT 2023. I have the pleasure of welcoming our esteemed faculty for dermatology, Dr. Cheshta Agarwal. She will be taking a session on dermatology. I am sure that she will provide valuable insights and perspectives on this important topic to all of you. Dr. Cheshta Agarwal is a MBBS graduate from Kasturba Medical College, Mangalore. She did her post-graduation in dermatology from R&T Medical College, Udaipur. She has got a further experience, a degree in cosmetic surgery and hair transplantation, and an experience of 7 years. Let's welcome our esteemed faculty who would be taking the topic of dermatology, Dr. Cheshta Agarwal. Over to you, ma'am.
Okay, so hello everyone. Good morning to all of you. So let's begin with our dermatology session. Can I get a quick thumbs up from all of you? So thank you everyone for, yes. So we should start with our dermatology discussion without wasting the time because we have 3 hours and I have to make sure that everything which is required for the exam, I have to cover it. Okay, so should we start? Can I get a thumbs up from all of you? Yes, good morning to all of you. Good morning everybody. Chalo, so we will start with the first topic of the today's class and that is your hair disorders. Dekho bachcho, since like last 3 to 4 years, I'm seeing that the question from hair topic is very frequently being asked and that is why I thought of putting it together here. Okay, should we start? Very nice. Good morning to all of you. Good morning everyone. Now we are starting with a diagram. Now here what I will do is I will show you a picture. You have to tell me what picture is this. And then what I will do, I will tell you what are the important expected questions out of that particular picture. Okay? So now putting the first picture on the screen, it is a picture. You can see that there was a patient who has some patchy sort of hair loss. It is very well defined patches. It is not diffuse. It is the localized type of hair loss. So can anybody guess what this hair loss can be? Very nice. I can see yes, this is your alopecia areata. Please remember students, alopecia areata say you have already got image based question. They can give you histopathology based question. The treatment is important. The type is important. Okay. So you can see first thing a patchy hair loss, which is a very characteristic feature of patchy hair loss, which is a very characteristic feature of alopecia areata. Now, can you tell me why this is not tinea capitis? In tinea capitis, which is the fungal infection of the scalp, you will see that there is patchy hair loss. Can it be tinea capitis? Anyone? What are the points which are against tinea capitis? Which is the dermatophytic infection of the scalp. If you look at this picture, you can see that the underlying, the skin which is present below, it has no scaling, it has no redness. It is absolutely normal. This means that this cannot be a patient of tinea capitis. In tinea capitis, the underlying skin has redness, it can show scales and patient will complain of itching. But here you can see that the underlying skin is absolutely normal. No itching. Obviously itching, there is nothing given in the symptoms, but there is no redness and scale which is visible. Clear? So please remember, no, not scarring. See, scarring, it is not necessary that all the patient of tinea capitis present with scar. That is not true. Scarring occurs only in the inflammatory type of tinea. In non-inflammatory type of tinea, for example, the black dot as well as the gray patch tinea, there is no scarring. In alopecia areata also there is no scarring. Then how to differentiate? There is only 2 features which differentiate the tinea capitis from that of alopecia areata is the underlying skin. If the underlying skin contained the redness, the scales, this has to be tinea capitis. No redness, no scale, this becomes alopecia areata. Understood this point? So this is very simple. Now, what are the things which you need to know for alopecia areata? Please remember that in alopecia areata, what happens? That T lymphocytes are formed against the pigment containing cell, pigment cell layer. So what happens? These pigment cell layers which are present around the bulb of the hair, this is your hair and this is the bulb of the hair. Somewhere here you have pigment containing cells, and in the patients of alopecia areata, the T lymphocytes will go and arrange themselves around this part of the hair, which is the hair bulb. Because of the T lymphocyte, the hair becomes thin, the hair will die, the hair will shrink, and you will observe a very classical tapering of the hair, somewhat like this. So hair will get tapered as it moves down. And what do you call this? Can anybody tell me what is this characteristic feature? When you see the tapering of the hair in the lower part, this is known as the exclamatory hair sign. Okay, so they ask you in exam, what is the exclamatory hair sign? Clear? So exclamatory hair is when you see that at the lower part towards the bulb, the hair is getting tapered, very classical of alopecia areata. And I can see few students telling me, which are absolutely right, what is this known as? The collection of T lymphocyte around the hair bulb. What do you call this? The collection of T lymphocyte or the peribulbar inflammation. Peribulbar inflammation which you see around the hair bulb, this gives you an appearance known as swarm of bee. This is known as swarm of bee appearance. Please remember, this is very important. Swarm of bee appearance, it's a feature of alopecia areata. Amazing. Okay? So clinical feature we have already discussed. It is the patchy hair loss. Dermatoscopy. What is dermatoscopy? This is not dermatology. This is dermatoscopy. Dermatoscopy means when you see it with a simple hand lens, you see an exclamatory hair. Now, can you tell me what should be the treatment of choice? If a patient of alopecia areata comes to you, how do you treat this patient? Can you just revise, recall it and tell me? The treatment of choice for this type of alopecia areata is intralesional steroid. Okay, remember this point, intralesional steroid. You have to give injection of steroid on these patchy hair loss. Okay, and what these steroids do, they will take care of the T lymphocyte which are present around the hair bulb. One more question which you get from this particular topic is, what is the nail change? Can you tell me what is the nail change in a patient of alopecia areata? You get uniform or geometric nail pitting. Uniform or geometric nail pitting. Okay, so this is very important. One more thing I want to mention here itself, students, please remember, from 3 consecutive year we are getting the question from the table or the classification of alopecia, that what are the non-scarring and scarring alopecia. Please make sure that you read that chapter. I'm very quickly telling you this. The non-scarring means where there is no scarring. Most of the time it is that part where the inflammation is very less. For example, telogen effluvium, anagen effluvium. For example, alopecia areata, tinea capitis, non-inflammatory types. These are the types of alopecia where the inflammation is very less. And if at all there is inflammation, it is not causing scarring of that area. And what are the example under the scarring alopecia? These are the lichen planus, DLE, the patient with frontal fibrosing alopecias, patients with any underlying serious issue where you have lot of inflammation which cause damage to the stem cells of the hair. So please remember, these type of 2 things can be asked in your exam: the difference of alopecia, what are the scarring and what are the non-scarring type, and this is an example of alopecia areata. So I'm very quickly writing it for all of you. If you have space, just write down here that the examples of scarring and non-scarring, scarring alopecia and non-scarring alopecia. They can ask you that in your exam. What are the scarring and the non-scarring alopecia? Yes, I'm writing it for all of you. The non-scarring alopecias, we have divided them into 3 A's and 3 T's. So please remember, alopecia areata, then anagen effluvium, then androgenic alopecia, which occurs due to the androgenic alopecia, which occurs because of the effect of androgen. The testosterons are getting converted to dihydroxytestosterone, causing more hair loss. What are the 3 T's? You have telogen effluvium, which usually occurs after the stress. Then trichotillomania, when you pull the hair and it causes hair loss. And I told you tinea capitis, non-inflammatory type. Tinea capitis, non-inflammatory type. These are the example of non-scarring. What are the example of scarring alopecia? Please remember lichen planus of scalp, DLE, discoid lupus erythematosus, frontal fibrosing alopecia. From this particular thing, we are getting question twice. Frontal fibrosing alopecia. Tinea capitis, inflammatory type. These are some of the examples. Please remember all my students. Okay, so example of scarring and non-scarring alopecia. Now what is this picture shows you? This picture is showing you just the peribulbar inflammation of the patients of alopecia areata. Remember I told you around the hair bulb you get lot of T lymphocytes. I told you here itself. Here we have discussed that if you take a biopsy from here, what do you get? You get a hair in the center. In alopecia areata, you get a hair in the center and it is surrounded by a lot of T lymphocytes, So this appearance is known as swarm of bee appearance. This appearance is known as swarm of bee appearance. Rushabh, what is dermatoscopy? Dermatoscopy is nothing, just a simple hand lens. When you examine the skin under the hand lens, you call it dermatoscopy. So it's just a magnified view of the cutaneous lesion. Understood this? So swarm of bee appearance, DLE is for discoid lupus erythematosus. Can I get a quick thumbs up from all of you if this is done? It is very simple. Now moving to the next and a second very important topic, and that is acne vulgaris. From acne topic we get a lot of questions, so I want all of you to know few things about acne. Can I change the slide, everyone? Great. Now acne, first of all they ask you, acne is the disease of which gland? Can you tell me the answer? Anybody can tell me? Acne vulgaris is a disease of sweat gland, sebaceous gland, or pilosebaceous unit. What is the correct answer? Anyone? Please remember, acne is a disease of pilosebaceous unit. It is not a disease of sweat gland. It is not a disease of sebaceous gland alone. It is a disease of pilosebaceous unit. Very frequently asked that acne vulgaris is related to hair and the sebaceous gland together, pilosebaceous unit. Can anybody tell me what is acne vulgaris? Acne vulgaris is a polymorphic condition. Polymorphic means it is a condition in which you get lesions of multiple morphology. Now, they ask you what is the characteristic lesion of acne. Please remember the characteristic lesion of acne is comedone. Characteristic lesion of the acne is comedone. If a patient presents to you with comedone, you have to always think of acne. So first thing is comedone, which is a grade 1 acne. Now what happens? It's a very simple logic. It's a very simple thing which you need to know. Now what is it? Let me just draw it here. This is the hair. This is your skin. This is the hair follicle. And inside the hair follicle you have a hair, right? So this is in the center you have a hair like this. This is your epidermis. This is your dermis. Now here you have your sebaceous gland. You all know that sebaceous gland at the time of puberty start producing sebum. So let's produce sebum. This is your yellow color sebum which is coming out through the sebaceous gland into the pilosebaceous unit or into the hair follicle. From the hair follicle it comes out on the surface of the skin. That is how a normal sebum drains. But what happens in the patient of acne? This unit get obstructed. There is a problem in this pilosebaceous unit. The first problem is there is an obstruction to the outflow like this. And because of the obstruction to outflow, what happens? That the sebum get accumulated here like this. This stage, when there is obstruction to the follicular outflow, you see a small bulge on the skin. This is known as comedone. There are two types of comedone, open comedone and closed comedone. Open comedone means when there is a slight opening. What happens? That there is a slight opening which remains like this here. And when there is a slight opening, the air enter and it causes oxidation of the sebum, turning it into black color. So open comedone is a black head. Because there's a slight opening in the obstruction, the air enters and the sebum get oxidized, turning it into black. But what is closed comedone? There's a complete obstruction and you can see the white sebum underneath. This is known as white head. So we have a black head and we have a white head. This is your grade 1 comedone. This is your grade 1 acne. You can see in this picture, can you see the black dot here? This is your open comedone. And if you see a picture here, this is your closed comedone. So we have two types of comedone, open and closed. Second is papule. For papule, you have actually, along with the comedones, what happens? There is multiplication of lot of bacteria. You should all know that inside your hair follicle, there are lot of normal bacteria, commensals, which is known as Propionibacterium acne. These organisms, they start proliferating in the presence of sebum and they causes little more bulge. This is known as papule. Now after some time, what happens? There is accumulation of inflammatory cells in your hair follicle. This is known as a pustule. And later on, what happens due to excess of sebum, bacteria, inflammatory cell, what will happen? Your hair follicle will rupture. And when your hair follicle rupture, you will get nodule and cyst. So these are the 4 grades of acne and these are the sequence of event which happens. So we will just label the diagram. This is your open comedone, blackhead. This is your closed comedone. This is your papule. This is your pustule. And you can see nodule and cyst. You can see nodule and cyst. I can just move here and I can show you that this is your nodulocystic acne. What happens? That the sebum is accumulating, the bacteria is proliferating and the inflammatory cells are also proliferating. So the hair follicle will stretch. Ultimately, it will rupture, giving rise to nodulocystic acne. So these are the 4 grades of acne. I hope everybody have understood. Very quickly, Kaushik, I'm explaining everything very quickly. First of all, acne vulgaris is a disease of pilosebaceous unit. That is the first thing which you have to remember. Now, what happens whenever there is obstruction to the hair follicular outflow, the sebum get accumulated. This is known as comedone. Now, sometimes there's a slight opening which remains in the comedone and it leads to the entry of oxygen. When the oxygen enters, it turns the sebum into black color due to oxidation. So we have 2 types of comedone, open, which is blackhead, closed, which is whitehead. Now second is, after some time, the bacteria proliferate and the clinical lesion becomes papule. Now after some time, the inflammatory cells will come inside the hair follicle. Then it is known as pustule. And because of overstretching, sometimes the hair follicle ruptures. This is your nodulocystic acne. Please remember, Anisha, it is not necessary that there is scarring. Scarring is not compulsory. It is not present in all type of acne. Okay, scarring only occurs when there is too much of inflammation, when there is lot of when the lesion when the inflammation reaches very in the depth of the skin. So it is not necessary that scarring occurs with every tissue or every acne. Understood this point? Okay, chalo. So these are the 4 types of acne. Now few things you need to know. What is the treatment of choice? Please remember, the treatment of choice for comedone is the topical retinoid. They ask you this in exam. Grade 1 acne, what is the treatment of choice? It is retinoid, topical retinoid. And what is the treatment of choice for grade 4? They ask you in exam. This is oral retinoid, which is isotretinoin. So please remember, oral retinoid, which is isotretinoin, is the treatment of choice for grade 4 acne. Now the most common side effect of isotretinoin, very important for exam. The most common side effect is, dryness of skin. And they ask you what is the another most serious type of side effect. Most serious type of side effect is teratogenicity. Can you tell me, can anybody tell me, if a patient is taking isotretinoin and if she is planning to get pregnant now, what should be the period of contraception they should follow? What should be the period of contraception after stopping isotretinoin? Please remember, students, if somebody is already taking isotretinoin, she has to stop it and she has to take an extra 3-month contraception after stopping it. Contraception after stopping isotretinoin. isotretinoin. 3 months of contraception after stopping isotretinoin. And if I ask you what is the contraception with acitretin, although it is not given in acne, it is given in psoriasis. In acitretin, it is 3-year contraception after stopping. Why I am writing it here? Because both isotretinoin and acitretin, they are oral retinoid. Isotretinoin given in acne, acitretin given in psoriasis. There's a difference. They both belong to same family. But isotretinoin, the period of contraception is 3 months, but for acitretin, it is 3 years. Okay? Chalo, done. So with this, we are done with almost all the questions which can be asked in your acne vulgaris topic. Coming to the second topic, or the next topic, which is the papulosquamous disorder. In papulosquamous disorder, remember students, psoriasis is a very important topic. You will get questions. I'm seeing continuously question being asked from this topic. Now, first of all, you should remember papulosquamous disorders are those disorders which presents with papules and scale. Now, in your exam, they will ask you, what is a papule? Can you tell me what is a papule? Papule is a solid raised lesion of less than equals to 1 centimeter. And when multiple papules combine, they form a large area, which is a plug. So what is it? It is a horizontally elevated lesion of more than 1 centimeter. Now, please, students, I would request everybody to write macule also. Macule also. Okay? Macule also you should write. What is a macule? It is a flat lesion. Flat lesion of less than 1 centimeter. It can be hyper or hypopigmented. Okay? Macule is flat lesion which can be hyper and hypopigmented. And what is a patch? What is a patch? It is a flat lesion of more than 1 centimeter. Can be hyper and hypopigmented. Can be hyper and hypopigmented. Okay? So these are some of the terminology which you should know, that a papule is less than equals to 1 centimeter. A plaque is more than 1 centimeter. Macule is a flat lesion. If you remember a patient of vitiligo, just imagine a patient of vitiligo. Vitiligo patient has hypopigmented macules or patches. If they are less than 1 centimeter, it is macule. More than 1 centimeter, it is a patch. Now, I could see some students asking me the treatment of acne vulgaris grade 2 and grade 3. Please remember, grade 1 मैंने क्या बताया? What did I tell you for grade 1 acne? Topical retinoid. For grade 2, it is antibiotic. It is topical antibiotic. So let me just go there and write, because I can see some students asking me that question. So very quickly I'm going here again. Papule ka treatment of choice is topical antibiotics, because here the bacteria is playing the role. And here the treatment of choice is oral antibiotic. Okay, oral antibiotic. So please remember the treatment. I'm just adding it here because some students were asking me that what is the treatment you will give in a papular stage, what is the treatment you will give in pustular stage. Can I get a thumbs up from all of you if this is clear? Everybody, if this is clear, just give me a quick thumbs up. And now I'm putting my slide here again. So macule, patch, and that is papule, and that is a plaque. Macules are not elevated, macules are flat. Macules do not elevate, they are flat lesions, while papules are elevated lesions. Clear? Now there's one more terminology which they will ask you in exam, and that is, what is a scale? Now, if you remember, my students, if you remember the basics of dermatology, can you tell me how many layers we have in our skin? 5 layers, right? In our epidermis, there are total 5 layers. Can you tell me one by one the name of all the layers? Stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Repeating it again, from outer to inside, outside to inside, stratum corneum, lucidum, granulosum, stratum spinosum, and stratum basale. If you remember, the first layer which is formed in our skin is stratum basale. The cells divide and they will ascend up and they will form different layer. When the cell reaches to stratum corneum, it will shed. After some time, it will shed. This is known as epidermal turnover. And what was the epidermal turnover time, if you can tell me? The total time taken up by this process, it is your 56 to 72 days or 8 weeks. Now, why am I telling you this here? Because what is a scale? If there is no shedding of stratum corneum cells, if stratum corneum get retained, clinically it will appear as a scale. So please write down here, what is a scale? It is the retained stratum corneum. It is the retained stratum corneum cell. Now, recently in INI-CT, we have a question. We have a match the following type. In NEET PT also, we have a direct question that what are the different type of scales, and this is a very important question for all of you. Please remember the answer of the question of epidermal turnover time. Do not get confused. Epidermal turnover. Those who are writing 28 days, that is not true. It is 8 weeks or 56 to 72 days. Remember this point. What are the different type of scales? Please remember. First is you have micaceous scale. Also known as silvery scale. And this is a feature of psoriasis. They look white like a silver. This is a feature of psoriasis. Silvery white or silvery micaceous scales. Psoriasis. Second type of scale, like a collar-like or collarette scale. Collar-like or collarette scale. This is a feature of pityriasis rosea. Third is fish-like scale. Fish-like scale. It is ichthyosis. It look like the fish skin. It is ichthyosis. Next is yellow greasy scale. Yellow greasy scale. Seborrheic dermatitis. Seborrheic dermatitis. And the last is mica-like scale. Mica-like scale. Please remember pityriasis, lichenoides chronica. Pityriasis, lichenoides chronica. So let me just little bit zoom out it. So now you can see all the names together. So we have silvery micaceous scales, which is a feature of psoriasis. Collar-like scale. Can you see the scales are present only on the border? And why they are known as collar-like? Because they are only attached with one margin, like a collar. Your collar is attached only with one margin. Other margin is free. Similarly, in this scale, only one margin is attached, other is free. Fish skin-like in the patients of ichthyosis. Yellow, dirty, greasy scale, patient of seborrheic dermatitis, and mica-like scale in pityriasis rubra, pityriasis lichenoides chronica. Okay, so acitretin, Janvi, acitretin is 3 years. Acitretin is 3 years. Okay, 3 years. Understood this? Any confusion till here? Chalo. So this is your scale. Please remember, scale is a secondary lesion. Now, very simple logic. Somebody is asking, ma'am, what is a primary and what is a secondary scale? Primary means the lesion which appears first. For example, a macule, a patch, a papule, a plaque, a nodule, a petechiae, or a telangiectasia. The lesion which appear first is a primary lesion, primary skin lesion. When these primary lesions modify, they form secondary skin lesions. For example, the secondary skin lesions are scales. The secondary skin lesions are scarring, whether it is hypertrophic scar or depressed scar. It can be an ulcer, it can be a fissure, excoriation, lichenification. So when you modify the primary skin lesion, it becomes the secondary skin lesions. Now coming to a very important topic of psoriasis. Please remember, psoriasis say you can get clinical image based question. What is psoriasis? It is a autoimmune T lymphocyte mediated skin condition in which patient develops well-defined, can you see, well-defined erythematous, red erythematous lesions with silvery scales. And please remember, psoriasis is a disease of extensors. Psoriasis is a disease of extensor. You see the lesions on knee, you see the lesions on elbow, you see the lesions on scalp. Please remember, lower back which is also known as gluteal cleft. ठीक है, so lower back or gluteal cleft, also on palm and sole. ठीक है, so please remember this, these are the two different type of scales, or sorry, these are the different locations of the lesions in a patient of psoriasis. Now somebody is asking me what is the difference between mica or micaceous scale. Please remember, micaceous is nothing, it is simply mean like a silvery scale, while mica you see small chip like. Have you seen a small chip or a chips like a flat thin scales which are attached on the skin? That is your mica like scale. So don't get confused. In exam they will give you mica and micaceous both separately. Okay, don't worry about that. Please remember, this is your very classical psoriasis, which is a disease of extensor, and it is a T lymphocyte mediated disease. Patient develops well defined papules and plaque on the extensors. Now there are some variants of psoriasis which is important for your exam, but before that let's do the nail changes. What are the different nail changes you get in a patient of psoriasis? Anyone? First of all, remember the nail changes occurs in around 50% of psoriasis patient. The most classical one is pitting of the nail. And what type of pitting is this? This is a irregular deep pit, also known as thimble pitting. It is known as irregular or deep pit, which is known as thimble pitting. Unlike in alopecia areata where you had a uniform pit, here you have irregular, non-uniform, deeper pit. What are the other changes? See, this type of change which you get in the nail is due to the nail matrix damage, pitting of the nail. Other feature is leukonychia. The nail become white, leukonychia, which is the whitish discoloration of the nail plate. White discoloration of nail plate. What are the other nail changes? You get oil drop sign. This is a feature of red lunula. The lunula which is white get red. Other is oil drop sign. What is oil drop sign? When you get a red or salmon plaque on the nail bed. You have nail plate crumbling. You have nail plate crumbling. Wrinkles on the nail plate. Wrinkles on the nail plate. And you get subungual hyperkeratosis. Subungual hyperkeratosis. They ask you in exam which is the most specific and the most common. Please remember, student, this is the most common nail finding in a psoriasis patient, and this is most specific. The oil drop sign is the most specific nail finding in the patient of psoriasis. Please remember, it is the most common and the most specific nail finding. Understood? So nail psoriasis, it is very important. Nail psoriasis is very important in the patients of psoriasis. Now students are asking me what is the status of CNS and mucosa. Please remember, in the patient of psoriasis, the central nervous system is not involved. Even though the scalp is the common site, but please remember CNS is never involved. Second point, in the patient of psoriasis, oral mucosa is not involved. So if you go to this slide here, please remember that the mucosa and the CNS, they are not involved. In the patient of psoriasis, we do not get involvement of these two areas. Understood this point? So please remember, these are the nail changes. Now in the patient of psoriasis, if you do a biopsy, what do you get? In the biopsy, please remember the characteristic feature is because of excessive proliferation, you get hyperkeratosis. Hyperkeratosis. Okay, this is red lunula. Now what are the findings on the histopathology? Please remember, on histopathology you get hyperkeratosis, which means increased thickening of stratum corneum. Second is parakeratosis. What do you mean by parakeratosis? Anyone? Parakeratosis means you see retention of nucleus in the stratum corneum cell. In the stratum corneum, normally there is no nucleus, but in the patient of psoriasis, you get retention of nucleus in the cells of stratum corneum. There is a collection of neutrophil in the stratum corneum. Can you tell me what is it known as? Micro-Munro abscess. Very characteristic. Collection of neutrophil. Collection of neutrophil in stratum corneum. Next, what is the status of stratum granulosum? No stratum granulosum, agranulosis. What you see in stratum spinosum, please remember, in stratum spinosum, you get acanthosis. Stratum spinosum mein you get acanthosis, which means increased thickness of stratum spinosum. You get dilated blood vessels in the dermal papilla. Dilated blood vessels in the dermal papilla, and there is thinning of the stratum spinosum just above the dermal papilla. Suprapapillary thinning. Suprapapillary thinning. Understood this? Now students are asking me what is the difference between parakeratosis and dyskeratosis. Dekho, parakeratosis simply means that the nucleus get retained in the stratum corneum cell. Normally nucleus is not present in the stratum corneum cell, but sometime it get retained. How and why? Whenever you have excessive proliferation, fast ascent of cell, the nucleus get retained, and this is known as parakeratosis. But what is dyskeratosis? Dyskeratosis means abnormal process of keratinization. When the cell is moving from the lower layer to the upper layer, there is change in the shape, there is loss of intracellular organelle, and this is known as process of keratinization. Sometimes this process of keratinization get abnormal, and this is known as dyskeratosis. Understood? This is known as dyskeratosis. Understood this point? So, is it visible now? Can I move it here? Now it is visible. So you have hyperkeratosis, means increase in the thickness of stratum corneum. Parakeratosis means retention of the nucleus. Then you have collection of neutrophils in the stratum corneum, Micro-Munro abscess. Agranulosis means absence of stratum granulosum layer. What do you mean by acanthosis? It means stratum spinosum is thickened. What do you mean by suprapapillary thinning? I hope you know that dermal papillas, the stratum spinosum just above the dermal papilla, it get thinned out, which is known as suprapapillary thinning. And what is dilated blood vessels? The blood vessels which are present inside the dermal papilla get dilated. I hope this is clear to all of you. Okay? Clear? What is acanthosis? It is increased thickness of increased stratum spinosum. Increased stratum spinosum is acanthosis. Increased stratum spinosum is acanthosis. Understood this point? Red lunula is means, what do you mean by red lunula? Somebody is asking me what is red lunula. Please remember, normally the lunula is white. If you see the proximal part of the nail, it is white in color. Sometimes there is some red dots which appears in your white lunula, and that is known as red lunula. Okay? Clear? Understood me? Now coming to the types of the psoriasis. We have discussed that psoriasis presents with well-defined plaques on the extensors. But there are some variants of psoriasis. First is pustular psoriasis. Sometimes you get pustules. They are sterile pustules, multiple sterile pustules. Multiple sterile pustules. Instead of plaque, patient develops pustule. It can be localized, which is limited to one part, or it can be generalized, which is present in a lot of areas. Generalized. Localized means the pustules are present only on one part of the body. And what do you mean by generalized? When the pustules are present on more part of the body. So two types of pustular psoriasis, localized and generalized. Sometimes in generalized pustular psoriasis patients, you get secondary systemic upset. Generalized pustule, all over the body there is pustule, and along with that you have systemic upset like pyrexia, arthralgia, increased polymorphonuclear cell. This type of psoriasis is known as von Jumbush disease. This is known as von Jumbush disease. A patient of generalized pustular psoriasis with systemic upset is known as von Jumbush disease. Okay. Understood this point? Now, this is the first type of psoriasis, which is pustular psoriasis. Now coming to the second, inverse psoriasis. If you remember, psoriasis is a disease of extensor. If it occurs on flexure, it is known as inverse psoriasis or flexural psoriasis. Okay? So if it occurs in the inverse part, exactly opposite parts like axilla, intermemory, groin, that is the flexural areas, you call it inverse psoriasis. There is one more type of psoriasis which is known as rheumatoid psoriasis. Rheumatoid psoriasis. And what is the characteristic feature of rheumatoid psoriasis? You get thick tent-like scale, thick tent-like or limpet-like scales. If you see here, if you see these scales, if you see here the scales, they are thick like a cone, like a tent. So thick tent-like or limpet-like scale is the rheumatoid psoriasis. So please remember, we have discussed pustular psoriasis, we have discussed inverse psoriasis, and we are now discussing the rheumatoid psoriasis. So the three variant, the pustular, the inverse, and rheumatoid. We have three more variants. We have three more variants. What are these variants? The erythrodermic psoriasis. What is erythrodermic psoriasis? It usually occurs when a patient of psoriasis take systemic steroid, systemic corticosteroid. When a patient take systemic corticosteroids, what happens? The well-definedness lost. The lesions of psoriasis, they all become ill-defined. They tend to spread and it covers more than 90% of the body surface area. So what happens in erythrodermic psoriasis? You get ill-defined generalized lesion. Ill-defined generalized lesion. Ill-defined generalized lesion on more than 90% of the body surface area. Please remember, students, although psoriasis is an autoimmune disease, we never give systemic steroid. The reason is, when you give steroid, the patient responds well. But when you stop these steroids, what happens? There is a sudden exacerbation of the inflammation, and this gives rise to exacerbation of the clinical lesion. This is known as rebound effect. Because of rebound effect, we never give systemic corticosteroids in the patient of psoriasis. We give topical but never systemic steroid because it converts the stable psoriasis into unstable variety like erythrodermic. The next variant which you need to know in a psoriasis patient is guttate psoriasis. Guttate psoriasis. Please remember, this is a variant which is seen in children. What happens in guttate psoriasis? What happens in this type of variant? In guttate psoriasis, remember students that you develop small raindrop-like like a coin. If you remember the 50 paisa coin, 25 paisa coin, they were small, right? So can you see the lesions are small? They are not large plaques. They are usually papules or small plaque like a coin. They are seen in children. Please remember, the lesions are more on trunk compared to that of extensors. So normally psoriasis occurs on the extensor, but this variant occurs on the trunk. You always get a history of sore throat or ear infection before the start of the condition, because this variant of psoriasis, it is triggered by group A beta hemolytic streptococcus. Group A beta hemolytic streptococcus infection. The treatment of choice in this condition is antibiotic. and the HLA which is associated is HLA-CW6. Please remember, all of them are exam question. All of them are exam question. Gutted psoriasis seen in children, small raindrop-like plaque, history of sore throat, treatment is antibiotic, HLA is CW6, HLA CW6. There is a trigger which is group A beta hemolytic streptococcus, and the common site is trunk more compared to that of the extensors. Understood? And the last variant, which is the commonest variant of psoriasis, is chronic plaque psoriasis. This is the commonest type of psoriasis, which is known as chronic plaque, and because it is commonest, you call it as psoriasis vulgaris. So the description which we always use, that there is a well-defined erythematous lesions present on the extensors, that is actually the description of chronic plaque psoriasis, which is also known as psoriasis vulgaris. Okay, chalo. So with this we are done with the variants of psoriasis. Now how do you treat? There's a lot of confusion with respect to the treatment. Please remember, psoriasis treatment depend upon the body surface area involved. If it is less than 20% of the body surface area, we only treat with topical therapies. Can be topical steroids, can be topical retinoid, can be vitamin D analogs. But if you have more than 20%, what do? You will give topical, but you will add an oral drug. And can you tell me which is the most preferred drug? It is methotrexate. So just remember that psoriasis, less than 20% body surface area, we give topical therapy. If it is more than 20%, what do? You add an oral drug. The most common is methotrexate. You can give some other drugs also, like cyclosporin, acitretin. Remember that acitretin, which we read with isotretinoin, where the period of contraception is 3 years after stopping the drug. Can I get a quick thumbs up? We are done with the psoriasis part. Coming to the next, Koebner's phenomena. Frequently we get this. What is Koebner's phenomena? Now what is Koebner's phenomena? Can anybody tell me what is the another name of Koebner's phenomena? Also known as isomorphic phenomena. Also known as isomorphic phenomena. Now what happens when a patient following trauma develops the isomorphic lesions on the lines of trauma? For example, I'm giving you a very simple example, and I give this example in all my classes. See, imagine there is a patient of vitiligo or psoriasis or lichen planus with the lesions mainly on the trunk. Now he met with an accident. Patient will observe that he developed the lesions of the primary disease on the sites of trauma. So trauma has triggered the pathogenesis. This is your Koebner's phenomena. So if we write the definition, in a patient with existing skin lesion, a patient with existing skin lesions develop isomorphic lesions on lines of trauma. On the lines of trauma, this is known as Koebner's phenomena. There are two types: true Koebner's seen in lichen planus, psoriasis and vitiligo, and pseudo Koebner's, it is a feature which is seen in the patients of infection because of auto-inoculation. Pseudo is because of auto-inoculation. Patient has a viral infection here, patient has scratched over here, and then he has scratched over here. So the virus from the nails, it has spread from this part to this part. So this is your pseudo Koebner's seen in viral what? Seen in molluscum contagiosum. MC means molluscum contagiosum. So you can get this image also. This is a PYQ. Can you see that in the line there's a scratch, or in the lines of trauma there is development of lesion? This is your Koebner's phenomena. Now coming to lichen planus. So some students were asking me few minutes back, ma'am, how to differentiate lichen planus from psoriasis. Please remember, lichen planus, how do you describe? Can anybody tell me the answer? How to differentiate the lesion of lichen planus from psoriasis? Anyone? How do you describe the lesion of lichen planus? 5P. You have a plain topped, polygonal, purple, pruritic papule. What was psoriasis? You develop papule also, plaque also. You have thick lesions, red lesions. You have scale. But what about lichen planus? Papule, flat topped, purple in color. So there is no confusion in psoriasis and lichen planus. So if you see the same page little lower down first, this is how you describe a lesion of lichen planus. You have plain topped, polygonal, purple, pruritic papule. And nowadays few dermatologists say that why to keep only 5 P's for lichen planus? Just give 3 more P's. And can you tell me some more P's which you can think of in the lichen planus patient? Anybody can think of some more P's. So you can also think of what is known as pterygium, which is a very classical nail finding. Please remember, in the patient of lichen planus, whenever there is healing of the lesion, they always leave behind pigmentation. So one more P is pigmentation. And nowadays, along with papules, sometimes we also develop plaque. So now you can add 3 more P's. Okay? So please remember, that is the classical description of lichen planus. Nothing more than this is required. When you see the lesions very closely with the help of a lens, you see white lacy lines on their surface. This is known as Wickham's triad. Now sometimes they ask you, what is the reason of Wickham's triad? The reason of Wickham's triad is, in the patient of lichen planus, when you do biopsy, you see irregular wedge shape hypergranulosis. So wherever stratum granulosum is thickened, you see a white line. So why it is not uniform? Because the hypergranulosis is non-uniform. So white lacy line on the surface is Wickham's triad, and the reason is hypergranulosis. Unlike psoriasis, which is a disease of extensor, lichen planus is a disease of flexor. You get it on the wrist, the flexural aspect of the wrist, and you get it on the ankle. Please remember, in lichen planus, the main problem in the patient of lichen planus is itching. Now imagine if you have itching, you will scratch and you'll get the relief. But in lichen planus, just scratching will not give them relief. They will keep on rubbing their skin like this, and that is why you never get excoriation marks, because lichen planus never put nail like this. No. They will never scratch their skin with the help of the nail. No, they will always rub. Either they will rub their nails against their skin, or they will use a cloth, or they will use a stone. So no stretch marks, no excoriations in the patients of lichen planus. Because of chronic rubbing, what happens? Their nail become thin, and that is the most common sign of the lichen planus nail. What is the most common sign? Thinning. Because of thinning, the nail plate changes its shape. This is your pup tent sign. Can you see this image? You can see very classical tenting of the nail. Nail plate becomes like a tent. Tenting of the nail plate. The most characteristic finding on the nail of a lichen planus patient is dorsal pterygium. Most specific is dorsal pterygium. Now what is dorsal pterygium? Can you see the proximal nail fold extended and fused with the nail bed? fused with the nail bed. Okay, so they will ask you in exam which is the most common and which is the most specific nail finding. You know this. The most common is thinning, and because of thinning the shape changes, pup 10 sign. What is the most specific? It is the dorsal pterygium, where the proximal nail fold goes and extends over the nail plate and fuse with the nail bed. Now just here for your information, please write somewhere here itself, if you get a question, where do you get ventral pterygium? Dorsal pterygium we get in lichen planus, but ventral pterygium, it's a feature of systemic sclerosis. Systemic sclerosis. So just make a bubble here if you can remember, not related to lichen planus. Because we have read dorsal pterygium, it's our duty to read the ventral pterygium also, where the proximal nail, instead of proximal, the distal nail fold extend over the nail plate. So this is the characteristic feature of nail in a patient of lichen planus. Okay, now coming to the histopathology. Lichen planus histopathology is very important for exam. So I want all my students to remember it. What is the finding of the what do you see on the histopathology in a patient of lichen planus? First is the stratum corneum get thickened, hyperkeratosis, thickening of stratum corneum, but there is no retention of nucleus without parakeratosis, and this is actually known as orthokeratosis. So the first finding in the stratum corneum layer is orthokeratosis. In the stratum corneum layer it is orthokeratosis. Second is, if you see here that you have irregular thickening of stratum granulosum layer. Stratum granulosum is this more dark layer and it is more thickened. This layer is stratum granulosum, which is irregularly thickened, known as wedge-shaped hypergranulosis. If you remember, I told you this is the reason of Wickham's trial. This is the reason of Wickham's trial. Okay, understood this point? This is an image of Wickham's trial. Now coming to the next part. Now, if you remember in our skin, how is your dermoepidermal junction? Like this. Okay, this is our dermoepidermal junction. You have rete ridges and dermal papilla which are very smooth. But what happens in a patient of lichen planus? The rete ridges becomes very sharp, very pointed like this. And this pointed rete ridges is known as sawtooth of rete ridges. So what is this? Can you see here? They are very sharp. This is known as very sharp rete ridges, known as sawtoothing of rete ridges. Sawtoothing of rete ridges. Sawtoothing of rete ridges. Just below the epidermis, at the junction of dermis and epidermis, you get collection of, can you see lot of blue dots? What is this? This is collection of T lymphocyte. Collection of T lymphocyte in a band-shaped manner, and this is known as interface dermatitis. This is known as interface dermatitis. So these are the 4 findings which you get when you see the picture in a 10x magnification, little broader view. Orthokeratosis, wedge-shaped hypergranulosis, sawtoothing of rete ridges, and interface dermatitis. Collection of T lymphocyte in a band-shaped manner. Now, if you see the 40x magnification, if you zoom the dermoepidermal junction, everybody, if you see here, this is your dermoepidermal junction. In the patients of lichen planus, the main problem is degeneration of the stratum basal cells. So what is happening? There is hydropic degeneration of stratum basal, and these stratum basal keratinocytes, they undergoes apoptosis. The apoptotic keratinocytes, they are known as colloid, cytoid, and civet bodies. Please remember, these dying keratinocytes which you see in the stratum basal layer, these apoptotic keratinocytes, they are known as colloid bodies or cevate bodies or cytoid bodies. And what happens, you all know that after apoptosis, the cell get dissolved. It just get, you'll see that the cell disappear. And what happens when the stratum basal disappear? You will see the presence of empty spaces. These empty spaces which you see once the stratum basal cells are gone, they are known as Max Joseph spaces. They are known as Max Joseph spaces. Through these spaces, the melanocytes fall in the dermis. And you all know that melanocyte, when it falls in the dermis, it produces the melanin in the dermis, and this melanin which is now present in the dermis give purple color to the lesion. Okay, it gives purple color to the lesion. Max Joseph space. Max Joseph space. What is this spaces? These are the sites where the keratinocytes have degenerated, have apoptosis. And when there is apoptosis, the empty spaces which are left behind, they are Max Joseph spaces. Clear? Can I get a quick thumbs up from all of you? Clear hai? theek hai? Done? So please remember what is orthokeratosis. Very quickly, I'm revising this slide. In the layer of stratum corneum, there is increase in the thickness, hyperkeratosis. But please remember, there is no retention of the nucleus. So this terminology where there is hyperkeratosis without parakeratosis is orthokeratosis. Second is stratum granulosum layer. It is thickened but irregularly thickened, known as wedge-shaped hypergranulosis. The rete ridges becomes pointed, known as sawtoothing of rete ridges. There is collection of T lymphocyte at the dermoepidermal junction, interface dermatitis. Now what happens? Because of the degeneration, the dying keratinocytes, they appear white or they appear pink. They are known as colloid body, cevate body or cytoid body, and with time these body disappears. They are known as Max Joseph space. Last part, how to treat a patient of lichen planus. Can you tell me what is the treatment of choice in a lichen planus patient? Anyone? In lichen planus patient, the treatment of choice is topical corticosteroids. Okay, so the treatment of choice is topical corticosteroids. Now coming to the next part. Now there is a variant which is known as lichen nitidus. We had a direct question from lichen nitidus in one of the exam. So please remember what is lichen nitidus. I'm just explaining, I'm just taking 1 minute and I'll tell you what is this lichen nitidus. If you remember, just now we have discussed that in the lichen planus, what is the main problem? In lichen planus, you have collection of T lymphocyte like this. And because of these T lymphocyte, there is damage to stratum basal. Very similarly, in lichen nitidus also, the T lymphocytes start collecting at the dermoepidermal junction. But what happens? In lichen nitidus, the rete ridges, they will elongate and they will try to hold the T lymphocyte at one site. They are not allowing the T lymphocyte to arrange in a band-shaped manner. They are just localized to one area because of elongation of rete ridges. And because of this, please remember the damage to the stratum basal is very, very minimum, very, very less. This classical histopath appearance is known as claw clutching ball appearance. Can you see it here? Lichen nitidus mein, this is the rete ridges which is elongating, and you can see a lot of blue dots, which is the T lymphocyte, which is which is localized to a one particular area due to the elongated rete ridges. So please write down, you have claw clutching ball appearance. It gives you an appearance as if there is a claw which is clutching the ball, and because of this, the clinical feature is limited. Patient develop asymptomatic, skin colored, micropapule. Where are these lesions present? They are mainly present on extensors like dorsum of hand, also present on penile shaft. Please remember, it is a disease which is commonly seen in children. It's a condition which is commonly seen in children. Okay? It's a condition which is commonly seen in children. Not very common in adult. It is seen in young children on the dorsum of hand or on the dorsum of forearm. Along with that, you can see it on the penile shaft. It is not very common. I would not say that it is something which is very common, but yes, you do see these patients. Coming to the next part, the next important topic which is asked, and I've seen recent question, and that is pityriasis rosea. Can you tell me what is the causative agent of pityriasis rosea? Anybody? Who causes pityriasis rosea? Please remember, it's a viral infection. Pityriasis rosea is a viral infection. And what is that virus which causes HHV7? Please remember, human herpes virus 7 causes pityriasis rosea. Now, what is the clinical presentation in pityriasis rosea patient? They will have a prodromal stage. You all know that after any viral infection, there is a prodromal phase. Patient will have fever, joint pain, arthralgia, myalgia. After the prodromal stage, these patients develop a very classical single oval-shaped red plaque on their trunk, and this is known as Herald patch. So what is it? It is a single oval erythematous red color plaque on trunk, and there is a very classical feature. What is the classical feature? That they have scales on the margin. Now I'm just giving everybody, please listen to me. Everybody listen to me. This is known as the Herald patch. Imagine this patch is over here. And if you see this patch from the top, it will appear somewhat like this. A oval shaped red plaque with scales in the margin. Imagine it is present here and I'm looking at the plaque like this from the top. It appears like this. Now imagine I'm seeing this plaque from the side. I'm seeing this plaque from the side. How will it appear? This will appear like this. There is a plaque and the scales are present like this on the margin, and you can see that the scales are connected to the plaque only from one margin. Now students tell me that ma'am, we are not able to imagine. Please think of a puri. I hope everybody have taken puri or chola bhatura sometime in their life. Imagine a puri. In a puri, you see that there is a thick base and there is a thin fluffy top. Just eat that thin fluffy top from the center. You will observe that in your puri there is still a thick base and a thin fluffy corner. That thin fluffy top is still attached to the puri from the margin. Very similar to this. So this is your thick base, this is your plaque, and the scales are only present on the margins, attached only on the margins, free from the center like a collar. So this is known as collar-like or collarette scale. This is collar-like or a collarette scale. Very classical collar-like or collarette scale. Okay, understood this? Chalo. So we are not discussing more on baturas and puri right now. Just remember, the example was given to understand the collar-like scale. They are attached like a collar only from one margin. The other margin is free. Now what happens after 1 to 2 weeks of this Herald patch? Patients start developing multiple small plaques like this. They are arranged in a very classical Christmas tree or fir tree pattern. The arrangement of the daughter patches is in a Christmas tree or a fir tree pattern. And please remember students, after a period of 6 to 12 weeks, there is spontaneous resolution. We do not give any antiviral. It get healed on their own. No need to treat them with any antiviral drug. So please remember, this is your pityriasis rosea. Everything is important: daughter patches, Herald patch, type of scale, causative agent, and treatment of choice. Okay, so please remember, this is very, very simple. Okay. Okay, some students are asking me why this is not silvery scale. Please remember, silvery should be uniformly present on the plaque, but this is only present on the margin, right? If it is present only in the margin, you will not call it as silvery white scale. This is collarette scale because they are present only on the margin. Now coming to the vesiculobullous disorder. We are done with papillosquamous and now coming to the vesiculobullous disorder. Please remember students, vesiculobullous disorders are those disorders where you have vesicle or bulla. Now I'll give you a very simple tip. Whenever you get a question of vesiculobullous disorder, how to solve it? Because they will ask you pemphigus, they will ask you bullous pemphigoid, and it is important for us to solve. So please remember, whenever they give you that, always look at the question, whether they have mentioned that the bulla is flaccid or it is tense. This is very important. Flaccid bulla means that the roof of the bulla is thin. It's a feature of intraepidermal split. And the example of intraepidermal split is pemphigus vulgaris, pemphigus foliaceus. Okay, so for intraepidermal split, we have pemphigus vulgaris or we have pemphigus vulgaris and pemphigus foliaceus. Okay, somebody is asking me what is hanging curtain sign. Please remember, when you see the herald patch, just 1 minute, everyone listen to me. When you look at the herald patch, you see some vertical lines on their surface. That is known as hanging curtain sign. So don't get confused with that. Okay, so herald patch may you get hanging curtain sign. So both the first two images here, this is also herald patch, this is also herald patch, and actually this has some vertical lines, and this is your hanging curtain. Okay, so please don't get confused, all of you. Hanging curtain sign. This is your hanging curtain sign. Understood? Chalo. Now coming to the, I was telling you about the flaccid bulla or tense bulla. So whenever the question say flaccid bulla, think of pemphigus vulgaris and pemphigus foliaceus. And when they say tense bulla, it is subepidermal split. Bullous pemphigoid, pemphigoid gestationalis, and linear IgA disease. So always think of these three DDs when you get a tense bulla, and when you get a flaccid bulla, you have to think of pemphigus vulgaris and pemphigus foliaceus. Now here only I'll just tell you very briefly how to get the answer. If the question say flaccid bulla, the next thing, look at the status of mucosa. If they say that the mucosa is involved, it becomes pemphigus vulgaris, and if they say mucosa spared, it becomes pemphigus foliaceus. Simple. Answer done. Flaccid bulla with involved mucosa vulgaris, flaccid bulla with no mucosa foliaceus. If they get tense bulla, if they give you tense bulla, please remember, in tense bulla most of the time, you see presence of itching. If you have itching, and if they say that a patient is elderly patient with itch associated with bulla, this becomes bullous pemphigoid. If they say it is a pregnant female with itchy bulla, it becomes pemphigoid gestationalis, and if they say it is a child with itchy bulla, it becomes linear IgA disease. So this is a very simple method of solving the question of vesiculobullous disorder. Look at the type of the bulla, flaccid or tense. Flaccid may two options, vulgaris, foliaceus. If they say vulgaris, mucosa should be involved. If they say foliaceus, mucosa not involved. Second is tense bulla. There can be three DDs. If it is bullous pemphigoid, elderly patient, and it is associated with itching. In pemphigoid gestationalis, it is a pregnant female associated with itchy bulla, and in a linear IgA disease patient, it is a child which is associated with bulla. Understood this point? Clear hai? Any confusion to anyone? Great. Now coming to the next part. Okay. Now let us discuss each of them one by one. Now first of all, sometimes they ask you the definition of vesicle and bulla. Yes, I will explain this little bit more in detail, don't worry. First is vesicle. What is a vesicle? It is a fluid-filled lesion of less than equals to 1 centimeter. What is a bulla? What is a bulla? It is a fluid filled lesion of more than 1 centimeter. That is a bulla. And I told you there are two types of bulla, either flaccid or tense. Now sometimes what happens, it is not necessary that always they will give you a history that a vesicle and bulla is present. And it is not necessary that all the patient will come to you with an intact vesicle and bulla. Imagine there was a patient coming to you and when he was entering your OPD, there was a rupture, there was a trauma and there was a rupture of bulla. What will you get? When the roof of the bulla get removed, the lesion which you get is a erosion. So loss of superficial layer is erosion. And sometimes what happens, the fluid of the bulla, it comes out and it get dried on the skin. This is known as crust. This is what? Dried exudate. Please remember, vesicle and bulla are the primary lesions while crust and erosion are the secondary skin lesion, because after the vesicle and bulla, the crust and erosion have occurred. When the bulla ruptured, erosion and crust have appeared. So that is why the erosion and crust are secondary lesions while they are the primary lesions. Vesicles and the bulla, they are the primary skin lesions. Understood this point, everyone? Okay. Now there are some very important signs, the bedside test which you need to know. One of them is Nikolsky sign. Now what is the use of Nikolsky sign? Nikolsky sign help us to know about the activity of the disease. Why we need to know the activity? Because if a patient of vesiculobullous disorder comes, it is important for us to start the treatment. Now what should be the dose of these steroids we have to start? That depends upon the activity of the disease. It's a very simple test. Imagine a patient presented with a bulla over here. Now what I will do, with the help of thumb or a blunt object, I will give a tangential force on the skin surrounding the bulla. Just surrounding the bulla, the normal skin, we will put a tangential force, and if you see that the skin got split like this, this indicates that the Nikolsky sign is positive. So please write down, everyone. It tells you about the activity of the disease. Tangential force applied. Tangential force on the surrounding normal skin. If you apply a tangential force on the surrounding skin, and on applying this, if you see splitting, this indicates that Nikolsky sign is positive. It means that if the surrounding skin shows erosion, splitting, it means that the disease is active. Already the surrounding skin has damaged and there is a chance that the bulla will progress. So please remember, this is a very classical feature of intraepidermal split. It is only positive in intraepidermal split. There are two types of Nikolsky sign which you all need to know. One is known as marginal Nikolsky, known as indirect, and second is distant Nikolsky, known as direct. If you apply pressure on marginal skin just near the intact bulla, if you apply the pressure on the skin near the bulla, it is marginal, and if you apply pressure on distantly placed skin. Now what do you mean by this? Let me explain this. Now imagine, everybody look at me, just imagine that you have a bulla over here. You have a bulla over here. If I am applying the pressure near the bulla, here only, this is your marginal Nikolsky. But imagine the bulla is here, but I am applying the pressure over here. This means that I am performing a distant Nikolsky. Now what is the significance? If the disease is very, very severe, even the distant skin will show splitting. But if the disease is less severe, only the marginal skin will split. The distal will be normal. It means disease is not widespread. It is localized. Understood this point? So please remember, Nikolsky sign indicate the activity of the disease. On applying the tangential force, if there is splitting of the skin, this is your Nikolsky sign. If splitting occur in the marginal skin, this becomes marginal Nikolsky, and if the splitting occurs in the distant skin, this is known as distant Nikolsky. This is known as distant Nikolsky. Okay. Now somebody is asking me, ma'am, what is impetigo herpetiformis? You have forgot to tell about that. Impetigo herpetiformis. Okay. If you're done with this, we can go to that part. Yes, इतना दूर भी split हो सकता है. Yes, you are totally right. इतना दूर भी split हो सकता है. Now, everybody, just come back to the psoriasis wala page. I think this part students are asking. If you come to the type of psoriasis, this page, I don't know what is the page number of this slide, but impetigo herpetiformis is the severe form of psoriasis, severe form or the unstable psoriasis in a pregnant patient. Unstable psoriasis in a pregnant patient is known as impetigo herpetiformis. And please remember, the treatment of choice here is oral steroids. Okay? So I'm discussing little bit page number 1022. Those who have not found the page, it is page number 1022. What is impetigo herpetiformis? When you see psoriasis in a pregnant patient, in pregnancy, sometimes the psoriasis become worse. It becomes more extensive, more severe. That is known as impetigo herpetiformis. And for this type of psoriasis, there is an exception. You have to treat this psoriasis with systemic steroids. You have to treat this type of psoriasis with systemic steroids. Okay? I hope Nikolsky is also clear. Can I get a quick thumbs up from all my dear students? Distant Nikolsky can occur positive in a lot of conditions. Please remember, Nikolsky sign, I told you, it is seen in intraepidermal split. So there are a lot of examples of intraepidermal split. We have discussed pemphigus vulgaris, pemphigus foliaceus. Even in drug reactions like SGS10, you can get the intraepidermal split, and hence the Nikolsky sign becomes positive. Chalo ji, badhiya. Now let's go to the next part, the diagnosis, which is the Zhang smear. They ask you Zhang smear. What is Zhang smear? Everybody listen to me. In a patient of pemphigus, you remove the roof of the bulla. You scrape the floor and you stain the material with the Giemsa stain. This technique is known as Zhang smear technique. I am repeating again. Imagine a patient of vesiculobullous disorder, that is pemphigus. You have a bulla here. I will take a scalpel. I will remove the roof. When I remove the roof, the fluid will go away. Now with the help of scalpel, I will scrape the base. Whatever material I got, I will spread it on the glass slide and will do Giemsa stain. This is known as Zhang smear. In pemphigus patient, you get acantholytic cells. What is acantholytic cells? They are round keratinocyte. Large hyperchromic nucleus, and there is a perinuclear halo. Okay, there is a perinuclear halo. So we have a large round cell with large hyperchromic nucleus and a perinuclear halo. This cell, acantholytic cell, is also known as Zhang cell. So don't get confused in the exam. Same thing, Zhang cell, because it is seen under the Zhang smear. Now there is one more under the Zhang smear. If you do a Zhang smear in a viral infection, especially herpes, you get what is known as multinucleated giant cell. So if you know that even in viral infections you have blisters, in herpes, in zoster, in varicella you have viral infection, and in these viral infection also, if you do a Zhang smear, you see presence of multinucleated giant cell. This was actually a recent question in one of the exam. Understood this point clear hai? So please remember, Zhang smear finding, they can give you this in your exam. You can get this image directly. You can see separated cells, and here you have multinucleated giant cell. Now histopathology, very important. What do you get on histopathology in a pemphigus vulgaris patient? You get suprabasal split. and you get intact stratum basal cell, you will see that the stratum basal cell, they are still connected to the stratum basal cell are still connected to the basement membrane, and this is because of a glue which is present on the undersurface known as hemidesmosome, intact hemidesmosome. And what is this appearance known as? This is known as row of tombstone appearance. This is known as row of tombstone appearance. Clear? This is known as row of tombstone appearance. Everything here which I have given, it is important question that whenever you have intact stratum basal, why the stratum basal remain intact? Because of a glue which is present on the undersurface known as hemidesmosome, and this appearance of intact stratum basal this is known as row of tombstone appearance. Okay? So you see a suprabasal split. It is intraepidermal also, right? Intraepidermal, just above the stratum basal, there is a split. This is a very classical finding in a patient of pemphigus vulgaris. Okay? In the patient of pemphigus vulgaris. Very, very classical sign. So you first write that and then I'll put the last slide again. Okay? You first write this. If this is done, I just want a quick thumbs up from all of you. If this is done, I'll put the last slide again. So row of tombstone appearance is very, very important. Okay, so this is the last slide. Those who are not able to complete this, please write down Zank smear, which is a feature of the pemphigus group, that is pemphigus vulgaris and foliaceus, and the viral infection shows the multinucleated giant cell. Okay, now students are asking me what is Auspitz sign, ma'am. Can you cover Auspitz sign? Okay, I'll cover the Auspitz sign also. Just give me some time. Let me cover this vesiculobullous disorder. Before going to the next part, I'll cover the Auspitz sign also. Okay, chalo. Now coming to the immunofluorescence. What is the direct immunofluorescence finding? Please remember the DIF finding. I will write here only, lower down, the DIF finding of the DIF finding in a patient of pemphigus vulgaris or in pemphigus group you get intercellular IgG deposits, and they will give you a very characteristic fishnet or chicken wire appearance. They will give you a very classical fishnet or chicken wire appearance. You will see presence of intercellular deposits of IgG known as fishnet or chicken wire appearance. Now coming to the next part. This is your immunofluorescence, direct immunofluorescence in a patient of subepidermal split, that is bullous pemphigoid. What is bullous pemphigoid? What is the immunofluorescence finding in a bullous pemphigoid? You get linear deposits of IgG along the basement membrane, zone, and this is known as ribbon candy appearance. Ribbon candy appearance. Now few students are asking me what is the difference between the direct and indirect immunofluorescence. See, direct immunofluorescence means we are taking the biopsy of the patient and we are just putting the serum of the or we are just putting the artificial antibodies on the biopsy sample. So we are doing it directly. But what is indirect? In indirect immunofluorescence, what we do, we take the serum of the patient and we put that serum on the biopsy of some of the animal tissue. For example, we take the esophagus samples, or we take some bronchus samples of the animals. So that is known as indirect, where we measure the autoantibodies in the serum of the patient. Here we are measuring the site of the antibodies, autoantibodies on the patient's skin. So direct and indirect, the only difference is the sample taken from the patient. Understood this point? BMZ is the basement membrane zone. ठीक है, and I just want everyone to write down the DIF finding of dermatitis herpetiformis also, because that is also frequently asked. Dermatitis herpetiformis, the DIF finding is you get granular deposits of IgA, and this is known as picket fence appearance. Picket fence appearance. Okay? Picket fence appearance. You get the granular deposits only on the tip of the dermal papilla. In dermatitis herpetiformis, the problem is only on the tip of the dermal papilla, so you get a very classical picket fence appearance. Coming to the next part. Okay, we are done with this. I hope this is clear to all of you. Now just explaining you what is Auspit sign, because few students were asking me. Auspit sign is, it is done on the patient of psoriasis. Everybody listen to me. Imagine there is a patient of psoriasis with a plaque over here. Now what I will do is I will take a glass slide. I will take a glass slide, and with the help of the glass slide, I will rub the plaque of the psoriasis like this. Now when I rub the plaque of psoriasis, because of rubbing, the scales will get disorganized and they will give an appearance as if they have increased. This is your first step of Auspit sign, known as Garatage test. Rubbing the plaque of psoriasis with a glass slide. Second is I will remove the scales. I will see a thin membrane known as Bulkeley's membrane. And step 3, when I remove the Bulkeley membrane, I will see pinpoint bleeding spot. This is known as Auspit sign. It's a 3-step process. Understood this? It's a 3-step process which you do in a patient of psoriasis. I'm repeating it again for all of you. Step 1 is you rub the glass slide. You rub the plaque with the help of a glass slide. This will cause exacerbation of scale. Second, remove the scale. When you remove the scale, you see a membrane known as Bulkeley's membrane. And when you remove the membrane, you see a pinpoint bleeding spot. Understood this point? Clear hai sabko? Okay? Can I get a quick thumbs up from all of you? So with this, we are done with the Auspit sign. Now coming to the next point, the next image is the cutaneous leprosy. Very, very important. What are the cutaneous lesion of leprosy? Now, first of all, whenever in your exam, in your question, if they give you that a patient present with a plaque with loss of sensation, always think in terms of leprosy. Leprosy is a condition which is an infective condition due to Mycobacterium leprae. Now M. leprae, because it needs only 30 degrees centigrade for its growth, it prefers the cooler areas of your body, like skin, like peripheral nerves. So peripheral nerves are frequently involved, giving rise to anesthetic patches. So in your exam, if you get a question which says, that a patient present with the plaques with loss of sensation, think of leprosy. Any confusion till here? Okay, any confusion till here? Okay, can I get a quick thumbs up? So loss of sensation and a plaque, think of leprosy. Loss of sensation, think of leprosy. Okay, now leprosy mein you must have read about the different forms. According to Ridley-Joplin classification, there are 5 types of leprosy. Okay. So according to Ridley-Joplin, we have tuberculoid TT leprosy, borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. This is according to Ridley-Joplin classification. This is according to the Ridley-Joplin classification. We have TT, BT, BB, BL and LL. Now, please remember students, all of them will have a different type of presentation. In TT, you get a localized disease, while in LL, you get a diffuse disease. And when you move from TT to LL, the disease becomes more diffuse. From the localized, it becomes more diffuse. Understood this point? Clear? Now, there's an image given in your workbook. Here. Now the first image is your TT leprosy, that is the localized type. Second is BT. This is your BB, BL, LL. Now I'll explain what happens just for few minutes. I request all of you just for few minutes, just look on the screen. Let us understand what happens in this type of leprosy. Now according to Riedler-Doppling, we have 5 types. In TT leprosy, what happens that the cell-mediated immunity is very strong. Patient generate very good immunity, and when the immunity is very strong, obviously the number of bacilli becomes very less. M. leprae are very less in the body. And obviously when it is very less, the disease becomes localized. Patient develop few well-defined plaque. Few, usually 1 to 5 well-defined plaque. This is your TT leprosy because of good immunity, few well-defined plaque. When you see these plaque, they have perpendicular outer margin and they have sloping inner margin. Can you see that the outer margin is perpendicular and inner margin is sloping like a cricket stadium? Perpendicular outer margin, sloping inner margin like a cricket stadium. This is very classical of TT leprosy, and this appearance is known as saucer placed upside. This is known as saucer placed upside. Now everyone listen to me, look on the screen. Everyone listen to me, look on the screen. Can you see this image? Can you see this image? This image, it is TT. You see well-defined plaque. And if you concentrate that the outer border are perpendicular and it is sloping in the inner like a cricket stadium, it is sloping in the inner and the outer part is perpendicular. This is your TT leprosy. This is your TT leprosy, which is known as what? It is known as saucer placed upside appearance. Saucer placed upside appearance. Clear? Can I get thumbs up, everyone, if this is clear? So this is your TT leprosy. Now when you move from TT to BT, what happens? CMI reduces. And obviously if CMI reduces, acid-fast bacilli increases. Now what happens here? The disease will start to spread. You will still get few lesions, 1 to 5, well defined. But what is extra? You get some satellite lesions, some small size lesions which are present away from the main plaque. So these are your satellite lesions. You can see here are your satellite lesions. I'm just highlighting it. That is your BT leprosy, borderline tuberculoid. And if you look at this picture, all of you, just look at this picture. Can you see these lesions? Some small lesions which are present away from the main plaque. This is your BT. This is your BT. You can see some satellite lesions which are present away from the main plaque. Understood? Okay? Clear? So we have TT and we have BT. TT and we have BT. Now as you move from TT to BT to BB, now when you move from BT to BB, CMI further reduces, acid-fast bacilli increases. Now here what happens? The number of plaque increases. You get multiple bilaterally asymmetrical punched out lesions. And this is known as Swiss cheese appearance because they are punched out. Swiss cheese lesion. Now when you see them from side, you will see that their outer margins are sloping and their inner margin is perpendicular, exactly reverse of TT. This is known as inverted saucer shape appearance. Exactly opposite of what you get in your TT patient. In TT, outer perpendicular, inner sloping, but in BB, outer is sloping and inner is perpendicular. So please remember, where you get inverted saucer, it is in BB. Inverted saucer in BB, also known as Swiss cheese appearance. And everybody, if you look on your screen, you can see this picture. Please look at this picture very carefully. You can see that all these plaques, they are punched out from the center and they are sloping on the margins. You have multiple plaques, but they are bilaterally symmetrical. On the body, they are asymmetrically distributed. They are not present symmetrical on both the sides of the body. This is your BB. Now, when you move from BB to BL, what happens? When you move from BB to BL, the CMI further reduces. CMI further reduces, acid-fast bacilli increases, and what do you get? In BL, if this is your trunk, you get multiple bilaterally symmetrical lesions. Multiple bilaterally symmetrical lesion. And when you reaches to LL, CMI reduces completely, acid-fast bacilli increases completely, and what do you get? You get diffuse infiltration. You get diffuse infiltration of skin, and there's a very classical appearance on the face known as leonine facies. So please remember everyone, this is important, how the changes occur in the clinical appearance from TT pole to the LL pole. The number of lesions are increasing, the acid-fast bacilli are also increasing, but the CMI of the patient, it keeps on reducing. Okay? Now, one thing I want everyone to write here itself, that what happens to the nerve damage, it runs in parallel to that of CMI, because the damage which occurs is due to our own immunity. So nerve damage is maximum towards the TT pole and it keeps on reducing towards the LL pole, such that in LL pole there is no loss of sensation. Okay? Understood? Everybody clear hai? Okay? So this is TT, BT, BBBL, and this type of classification is known as Ridley-Joplin classification. Recently there was a question asked in your exam that Ridley-Joplin classification is based on what criteria? Can anybody tell me the answer? Ridley-Joplin is based on which criteria? 4 criteria. And what are those 4 criteria? It is based on clinical criteria. It is based on immunological criteria. It is based on bacteriological criteria and histopathological. Why do you call the localized variety as tuberculoid leprosy? Because histopathologically it resembles tuberculosis. Okay? So Ridley-Joplin classification is based on 4 criteria. I have already marked it. The TT means histopathological, localized or diffuse, so clinical criteria, CMI, immunological and bacteriological criteria. Okay? So I hope this is clear. I can write it here also. 4 criteria: clinical, immunological, histopathological and bacteriological. Clear? Can I get a quick thumbs up? Okay? Please remember, nerve damage in lepromatous leprosy do not occur. Only in the later stages you get the presence of nerve damage. Now there's a lot of confusion. Students मुझसे पूछते हैं, students ask me, what is that cranial nerve which get involved first? So few questions. If you are done with this, can I get a quick thumbs up? I'm changing this slide. Everybody has to give me a quick thumbs up if this is clear. Okay? Can I get a quick thumbs up from all of you? Very nice. So I'm getting a lot of loves. Thank you all of you for that. Okay? Chalo. So now coming to the some questions. I just want everyone to put a dabba over here, make a box and write down some frequently asked question. The cranial nerve which is frequently involved. Please remember, cranial nerve number 7 is more frequently involved than cranial nerve number 5 when you have plaque of leprosy on face. Okay? Plaque of leprosy on face. It is the cranial nerve number 7 which is involved more frequently. Second, they ask you which nerve is involved first. Please remember, ulnar, more common, posterior tibial nerve. Third question, students ask me that which sensation is lost first? So please remember, it is temperature, cold, hot, then pain, then touch. That is the sequence of loss of sensation in a patient of leprosy. Yes, I'm very sorry, Surya, there's no space. If you can write somewhere along with that 4 pictures, or you can just adjust it somewhere. Okay, so please try to adjust it somewhere. So cranial nerve number 7, ulnar nerve, cold. Now one more thing is chemoprophylaxis. Recently we have a question, what is the chemoprophylaxis you give? I will teach you the treatment in some time, but you just write here in this dabba only, you give single dose of rifampicin. You give single dose of rifampicin. It is 600 mg for an adult and 450 mg for a child. Now, whom to give this prophylaxis? Whom to give the prophylaxis? Just I'll take few more lines here. We have to give if the exposed patient is more than 2 years, the duration of exposure is more than 3 months, and if the patient, if the contact spends more than 20 hours per week with the patient, share same roof and kitchen. Okay, so please remember these are some of the points which you have to remember. Ma'am, nerve involvement in LL or not? No, the nerve is not involved in lepromatous leprosy because CMI is very low. But please remember, students, if you do not treat LL patient, after some time, after a very long time of the illness, you can see some glove and stocking type of anesthesia, but you will never see loss of sensation over the plaque in the patient of lepromatous leprosy. Can I get a quick thumbs up? Okay. Please just give me a quick thumbs up if this is clear to all of you. Okay, now coming to the next page. What is AC? Where have I written AC? I don't know where I've written A or C. No idea. I forgot. So just help me. What students are asking me, A or C? Acha, roof and the same kitchen and the roof. Same kitchen and the roof. Now, please remember, we have till now read about Ridley-Joplin classification. There is one more classification system which is known as Indian classification system. In Indian classification system, please remember, students, that there are 4 types. There are 5 types in Indian classification system. Indian classification system, it has only one criteria, clinical criteria. Okay, acha, adult. Okay, so rifampicin in adult you treat by giving chemoprophylaxis of an adult is for 600 mg and in a child it is 450 mg. C is for child and A is for adult. Indian classification is of 5 type. You have tuberculoid, borderline, lepromatous, and there is 2 more. One is known as pure neuritic and indeterminate leprosy. So please remember, there are 5 types of classification. Under the Indian classification system, we have 5 types. One is tuberculoid, second is borderline, third is lepromatous, fourth is pure neuritic. Now please remember, students, in pure neuritic type, there is no skin lesion, only the nerve damage. Sometimes you get this dry patches because of the involvement of the nerve of the sweat gland. Second is indeterminate. What is the type of presentation in an indeterminate leprosy? In these patients, you will get ill-defined plaque on the face. So they are usually child. With ill-defined plaque, mostly single on face. No skin, no itching. Sometimes you see presence of atrophy. So this is your Indian classification system. 5 types: tuberculoid, pure neuritic, borderline, indeterminate and lepromatous leprosy. Clear? ठीक है, चलो. There are two variants of leprosy. One is known as histioid leprosy. Please remember, students, there are two variants of leprosy. One is known as histioid leprosy. Nowadays, we treat a patient of leprosy by 3 drugs. Can you tell me what are the 3 drugs? Anyone? How do we treat a patient of leprosy nowadays? Rifampicin, clofazimine, Depson. But previously, like 10 years back, we used to give only one drug in a patient of leprosy, and that was Depson monotherapy. When we were giving only Depson, during that time, we used to get a lot of patients with drug resistance, and these drug resistant cases, they present in a very classical form which is known as histioid leprosy. So please remember, what is histioid leprosy? Drug resistance cases. They are the relapse cases. This is when we were giving monotherapy. What is the clinical feature in these patients? Patient develop multiple asymptomatic nodules all over the body. Multiple asymptomatic nodule all over the body. Okay, so you want the previous slide? You just first write this slide. I'll put the previous slide again. You first write this slide. I'll put the previous slide again. So there is a variant of leprosy known as histioid leprosy. This type of leprosy, it used to occur in the relapse cases. When we used to give a single drug for treatment, in those times, we used to get a lot of relapses, and these relapse cases presents with multiple asymptomatic nodule known as histioid leprosy. In these patients, the acid-fast bacilli were very high in their number. They were present in groups, and these groups were known as globi. The acid-fast bacilli, they used to present in bundle, and these bundles are known as globi. So you can see these images. There are a lot of nodules which are present in these patients. Now, clear hai? ठीक है, done? ठीक है, so for those who want the previous slide, just give me a thumbs up if this slide is done. ठीक है, so the previous slide is this Indian classification system. In Indian classification system, we had 5 varieties. In Indian classification system, we have 5 varieties. One is tuberculoid, second is borderline, third is lepromatous, fourth is indeterminate, and fifth is pure neuritic. In pure neuritic, no skin lesion, only the nerve damage. While in indeterminate leprosy, you can see presence of single ill-defined plaque on the face, no scale, no itching. You can just see presence of atrophy. Okay, so with this we are done with that of the variants of leprosy. There is another variant. There is a second variant which you see in the leprosy is lucioleprosy. What do you mean by lucioleprosy? Lucioleprosy is known as lepra bonita. Lucioleprosy is known as lepra bonita or beautiful leprosy. Lepra bonita or beautiful leprosy. Please remember, it is only seen in Mexico. Now, why it is known as beautiful leprosy or lepra bonita? Because patient develop diffuse lesion, non-nodular. Now, everyone, imagine there is a patient. Imagine a 40-year-old female. He had a lot of wrinkles, sagging of the skin on the face. Suddenly she develops this type of leprosy, lucioleprosy. Now here what happens, there is a diffuse infiltration of the skin. The skin of the patient is now stretched. When you have stretched, your skin becomes shiny. There is no more sagging of the skin. Shiny skin in a female, what she will think? She will think that I'm getting beautiful. since I got this leprosy, I'm getting more and more beautiful, and that is why in Mexico, in their local language, this type of leprosy is known as lepra bonita. Okay? So you have diffuse non-nodular infiltration of the skin. But sometimes what happens due to the diffuse infiltration, because of skin shininess, there is a overstretching and the skin get ulcerated. This is known as Lucio phenomena. So what is Lucio phenomena? Ulceration of the skin due to overstretching. Ulceration of the skin due to overstretching. Okay? So this is Lucio phenomena. Because of overstretching, sometimes there is ulceration on the skin. Now coming to the treatment part. Now this is very important for all of you, because there were the questions from this topic of treatment. Now here everybody, I want you to please look on the screen. If you see on screen, you can see 4 strips. There's a green color, there's a red color, then you have here a blue color, and here you have a orange color kit. Please remember, I'm repeating it for all of you. Please remember, previously we used to treat the paucibacillary patient of leprosy with 2 drugs and multibacillary leprosy with 3 drugs. So we used to give the green color kit for pauci, and multi ke liye we used to give this maroon color kit. So these 2 are for adult, and for children, for pauci we used to give blue, and for multi we used to give orange. But listen to me, all of my students. Now we are not using these pauci kits anymore. No. For both paucibacillary and multibacillary, we are giving the same maroon color kit for adult and orange color kit for children. Now please remember, for paucibacillary, we are giving 6 packet, and for same 6 packet of maroon color, and for multi we are giving 12 packets of same maroon color. Understood this point? So there should not be any confusion. There should not be any confusion that there is green or maroon. There is only maroon color kit if it is an adult, and if it is a child, there is only one color kit, and that is this orange color kit. Okay? Orange color kit you have to give 6 packet for pauci and 12 packets for multi. Multi-child 12 packets. Okay, clear hai? Now very quickly I'm revising what is the dosage. Very quickly I'm revising what is the dosage. How do you treat the patient? Now if you see, just concentrate on this maroon color kit. If you see very carefully, on the maroon color kit there's a small blister and there's a big blister. On small blister, everybody please look on the screen. On the small blister, there are 2 tablets of rifampicin, 300 mg each. So this becomes 600 mg of rifampicin. This is the 3 tablets of clofazimine, which is 100 mg each. This becomes 300 mg. And this is your Depson 100 mg. Now please remember, students, whenever you diagnose a patient, you give a kit. You ask the patient to take the tablets which are present in this blister packet, which is rifampicin 600 mg, clofazimine 300 mg, and a single tablet of Depson. You ask the patient to take these 3 tablets or these 3 tablets in front of you. So they are supervised. Rifampicin 600 mg once in a month, clofazimine 300 mg once in a month, and Depson 100 mg. This is the supervised. Now once the patient take these drugs which are present in the smaller packet, you just remove that packet and throw it. The remaining packet will be given to the patient. If you see, if you just turn this packet, you will see that there is days written, day 2, day 3, 4, till day 28. There are some markings given on this kit. Every day patient has to take 2 tablets. Every day patient will take 2 tablets. If you see here, white is Depson 100 mg, and what is this red? clofazimine 50 mg. Please remember these tablets, Depson and clofazimine, Depson 100 mg and clofazimine 50 mg, this is taken by the patient on his own at home without supervision every day. Once the 28 days are over, the patient will not take this drug because the packet is empty. He will come back to you and will ask for a new packet. Now, when you give the new packet, you will do the same procedure. You will ask the patient to take the smaller packet first and then the remaining part of the packet. Clear this? Can I get a quick thumbs up if this is clear? So please remember, this is very important. This is the treatment of the multibacillary in adult, and what you give for a child, I'm just writing it here. Here you give rifampicin 450 mg, clofazimine is 150 mg, and Depson is 50 mg. In children, one day only Depson 50 mg, and on another day clofazimine 50 and Depson 50. So clofazimine has to be taken every alternate day, but Depson the patient will take every day. So please remember, that is the treatment of leprosy, which is very important. I'm not discussing more in detail. I hope this is clear. We have also discussed some important questions related to chemoprophylaxis, the cranial nerve involved, and what will happen, or what is the sequence of loss of sensation with that of leprosy. Okay, chale. So I have taken sufficient time to discuss leprosy because nowadays we are getting more and more questions out of this. Last part is lepra reaction. Sometimes when you give MDT, due to sudden killing of M. leprae, you get lepra reaction. Two types of lepra reaction. Type 1, everything is given. Type 1 is a type 4 hypersensitivity reaction. There's a very simple rule of 5. 1 plus 4 is 5. So just remember that type 1 is type 4 hypersensitivity reaction. This is mainly seen in the borderline group, BB, BL and BT. Now what will happen? The patient will observe that there is exacerbation of the existing skin lesion. Can you see the existing lesion becomes more red, more inflamed? You can even see that there is more nerve damage. This is your type 1 lepra reaction. While in type 2 lepra reaction, what do you get? In type 2, which is a type 3 hypersensitivity reaction, it is mainly seen in lepromatous patients. In these patients, you develop multiple painful lesions, which is known as erythema nodosum leprosum. Multiple painful lesions, erythema nodosum leprosum. Can you tell me how to treat the lepra reactions? What is the treatment of choice for lepra reaction? Anyone? How will you treat lepra reaction? Anybody can tell me the answer. First of all, make sure that you continue the multi-drug therapy. Do not stop MDT. The next treatment of choice is you have to add oral corticosteroid. So continue MDT and give oral steroid. Okay? So continue MDT and give oral steroid. So that is a very simple way to answer for the treatment of choice. Okay? So with this we are done with the leprosy also. So for those who are asking me for the treatment, please write very quickly. Do not give thalidomide. Somebody is writing thalidomide. Thalidomide is not considered treatment of choice for any type of lepra reaction because of its side effect. What is the side effect? The side effect is teratogenicity. The patient develops phocomelia if it is taken during the pregnancy. Okay? So please remember, for all the type of lepra reactions, you give oral steroid, systemic steroid, which is the treatment of choice. Very nice. Now coming to the STD part. First of all, let's see genital ulcers. Syphilis. What type of ulcer you get in a patient of syphilis? Syphilis, which is due to Treponema pallidum. You get a very classical painless hard ulcer. And these ulcers, they have a button-like consistency. Very classical button-like consistency. Now there is a condition where there is no primary ulcer. This is known as syphilis D. emboli. And what are those conditions? What type of Patient has no primary ulcer. Please remember, in congenital syphilis, there is no primary ulcer or no primary stage. And second is secondary to blood transfusion. In these two cases, primary stage is not seen. So please remember, you should know how does the ulcer of the syphilis look like. You can see it's a very quiet ulcer which is not painful, like a button, very hard in its its appearance is very quiet, and when you touch it, it gives you a very hard or a firm appearance like a button. So this is the primary stage of syphilis. It can occur anywhere, this ulcer, because this ulcer occurs at the site of entry of Treponema pallidum. It can occur on the genitalia, on the heterosexual intercourse. It can occur on the perianal skin, perioral area, fingers in a homosexual intercourse. Okay? Okay. So this is your primary canker. Now coming to the secondary stage. Once the treponema enter the blood from the primary stage, it can go anywhere on the body. And when it enter the blood, it presents with lesions anywhere on the body. This stage is known as secondary stage. But there are three classical lesions. One is known as condyloma lata. What are they? Flat, moist lesions on genitals. Second is mucus patch. Painless oral lesions. Sometimes in the oral cavity you have multiple small ulcers which combine to form a large ulcer known as snail tract ulcer. You see flat lesions on the palm sole known as macular syphilis. They are hyperpigmented lesions. Hyperpigmented flat macules. I told you what is macule. It's a flat lesion, neither raised, neither depressed. Neither raised, neither depressed. Okay? What is hard canker? Hard canker is the name of primary ulcer only. You can call it primary canker, you can call it hard canker. So whenever they write canker or hard canker, it is a patient of syphilis, the primary stage of the syphilis. In secondary stage, patient can develop any lesion. You can develop the lesion anywhere on the body, asymptomatic lesions anywhere on the body. But there are some classical lesions. One is condyloma lata, which are the flat lesions on the genitals, mucus patches, which are the painless ulcer in the oral cavity, and macular syphilis, which are the flat hyperpigmented lesions on palm and sole. Now, what is Buschke-Ollendorff sign? Please remember, I told you these lesions are painless. But sometimes when you press it with the glass light, it causes, or not the glass light, the pin, it can cause tenderness. So, Buschke-Ollendorff sign. It is the deep tenderness on pressing the lesions. With a pin head. Okay? You can also develop, in these patients, you can also get the moth-eaten type of alopecia. You can get generalized lymphadenopathy. That is the feature of secondary syphilis. Now, what happens after secondary? Sometimes patient develops no cutaneous sign and signs and symptom, but still patient has live treponemas in their body. Can you tell me what stage is this? That stage is known as latent stage of syphilis. So please remember, after secondary, there is a stage where there is no cutaneous sign and symptom known as latent, and after latent, there is a stage which is known as tertiary. In tertiary stage, patient develops gamma. That is the necrotic ulcer on the skin, and you get cardiovascular syphilis. Due to the involvement of the blood vessel, patient develop aortic aneurysm. Aortic aneurysm. And also patient develop cardiovascular syphilis. Central nervous system, CNS syphilis. Neurosyphilis. So that is the tertiary stage when the local tissues start responding. Now few students are asking me what is condyloma acuminata. Please remember students, condyloma lata is the lesion of syphilis, but condyloma acuminata is the lesion of human papilloma virus, genital wart. Here we have read about lata. After some time I will teach you about condyloma acuminata. Okay? What is great imitator? Students are asking me why it is called as great imitator. Because the treponema is in blood, so it can go anywhere in the body and it can mimic any disease, and that is why we are calling it as great imitator. Then how will you diagnose a patient of secondary syphilis? By looking at these classical symptoms. If you see any of them, then this indicates that you are dealing with a patient of syphilis. Okay. Gamma is a necrotic ulcer. Now in congenital syphilis, there is a very classical triad known as Hutchison triad, and I always ask my student to remember it with the Gandhiji's three banda. Remember the three monkeys of Gandhiji. Bura mat dekho, bura mat bolo, bura mat suno. So please remember three features: Hutchison teeth, eighth nerve deafness, and interstitial keratitis. How to differentiate the congenital syphilis from an adult patient? Please remember, you do not have any primary stage. In the secondary stage, the first cutaneous lesion is vesicle and bulla. Please remember, in adult we never get vesicle and bulla, and this is known as syphilitic pemphigus. This is known as syphilitic pemphigus. And please remember, the tertiary stage in a congenital syphilis, please remember, no cardiovascular system involvement. The cardiovascular system involvement is not present. So please remember that the congenital syphilis differs from the adult. How it differs from the adult? First of all, no primary stage. I told you, syphilis diemle, one of the example is congenital syphilis. In secondary stages, the main clinical sign and symptom is vesicle and bulla. And along with that, please remember that tertiary stage do not contain any cardiovascular system involvement. Okay? There is no cardiovascular system involvement. Kanishka, the first cutaneous sign is vesicle and bulla. We are not talking about other features, just cutaneous sign is vesicle and bulla. Now, because congenital syphilis occurs in a child who is growing, you get a lot of developmental deformities. In a growing child, you get a lot of developmental deformities. And what are these developmental deformities? Please write down. Saddle nose. The bridge of the nose, it gets ruptured and the roof settles down. Second is Hutchinson teeth. What is Hutchinson teeth? Broad central incisors. There is gap in between. And if you see, their distal margin is cup-shaped. Third is Clutton joint. Painful joint swelling. And because of painful joint swelling, the child refuses to walk, giving rise to pseudo paralysis of parrot. Giving rise to pseudo paralysis of parrot. You also get saber tibia. There is thickening on the anterior part of the tibia. Thickening on anterior part. And because of this thickening, can you see there is a thickening? Because of thickening, it gives an appearance of bowing. So you also get bowing of tibia in the patients of congenital syphilis. So the four deformity is the saddle nose, Hutchison teeth, Clutton joint, and saber tibia. There are few more things which you see. There is a joint defect which is known as Wimberger sign, where you have irregular erosions of the epiphysis. If you remember in scurvy, you must have read about Wimberger ring sign. But in the patient of congenital syphilis, there is Wimberger sign. Okay, so please remember Wimberger sign. Then you have Olympian brow. that is frontal bossing. Okay, so there is Olympian brow, which is frontal bossing. How to treat anyone? How to treat a adult patient of syphilis? The treatment is benzathine penicillin, 2.4 million international unit, given intramuscularly. And for a child, what is the treatment? Crystalline penicillin G, given in a dose of 50,000 international unit per kg, IV, 4 to 6 hourly, 10 days. Please remember that's a treatment of syphilis. If it is an adult patient, we prefer giving benzathine penicillin. But for children, we give crystalline penicillin G. The reason is because in children, the chances of CNS involvement is more. And for CNS disease, we prefer crystalline penicillin G because there's a better crossing of blood-brain barrier. And that is why we prefer giving crystalline penicillin G in the dose of 50,000 international unit. It is given intravascularly 4 to 6 hourly for 10 days. Okay, so that is about syphilis. Clear? Can I get a quick thumbs up? Okay, so yes, I cannot go away from the screen, so I have to be somewhere in the screen only. So please give me a quick thumbs up if you are done with the syphilis part. Now we are coming to the second, that is chancroid. Please remember, syphilis के ulcer को we were calling hard canker. But what is the ulcers of chancroid known as? The ulcers of chancroid are known as soft cankers because they are soft to touch. You get multiple ulcers which are painful. So please write down chancroid, which is due to Haemophilus ducreyi. Chancroid due to Haemophilus ducreyi. You get painful multiple ulcers with undermined edges. You also get painful lymph node enlargement. You get painful lymph node enlargement, which is known as bubo, and these are known as soft canker. Please remember, soft canker is a feature of chancroid. Okay, 2.4. This is 2.4 million international unit. 2.4 million international unit. Those who are getting confused. Okay, and yes, I always ask my student to remember a very simple mnemonic, that syphilis ko you can remember as less, because you get painless ulcer and painless lymph node. And Haemophilus ducreyi, chancroid, you can remember Haemophilus ducreyi. And in Hindi, they say, right, dukh raha hai. So dukh raha or dukh. So because you have painful ulcers and painful lymph node, so Haemophilus ducreyi. Understood this point? Okay. Clear? Can I get a quick thumbs up? Now few questions. Students are asking me, what is Wimberger sign? Wimberger sign is just erosion of epiphysis, but it is irregular. Unlike in scurvy, which is regular, here you get irregular erosions of epiphysis. That is Wimberger sign. Okay. Now what is Kassovitz law? Somebody is asking me Kassovitz law, so I'm just telling it very quickly. Kassovitz law says that the untreated pregnant female, the pregnancy outcome improves with time. It means, imagine there was a pregnant female who got positive for syphilis during her first pregnancy, and now she presented with her third pregnancy. She told that she was diagnosed as syphilis during her first pregnancy. Now she came to you for third pregnancy. The risk of getting congenital syphilis during her present pregnancy is less compared to her past pregnancy. This is known as Kassovitz law. Okay, so with this we are done with chancroid also. And chancroid mein, if you do a gram stain, what do you get? School of fish appearance. If you do gram stain of syphilis patient, this is known as, sorry, not syphilis, this is a Haemophilus ducreyi patient, chancroid patient. If you do a gram stain, you get school of fish or railroad track appearance. Coming to the next, that is granuloma inguinale or donovanosis. What is the causative agent of donovanosis? It is Calimactobacteria granulomatis. Also known as Klebsiella granulomatis. Now, what is the characteristic feature? The clinical feature is patient develop red exuberant ulcer with granulation tissue which bleeds on touch. Please remember, no lymph node enlargement. No lymph node enlargement, but sometimes there are some soft tissue swellings on the groin, and these are known as pseudobubo. So just write somewhere here only that in these patients you get pseudobubo. They are not actually lymph node, they are soft tissue swellings. When you do Giemsa stain in these individuals, you see intramacrophage bodies. You get intramacrophage bodies, and what are these bodies known as? They are known as bipolar bodies or safety pin bodies. They are also known as Donovan bodies. So bipolar bodies or safety pin bodies, they are also the other names of this condition. So I hope I'm not coming in front of your view. Okay, so granuloma, inguinale or donovanosis, all these features are important. You can see that there's a red exuberant ulcer. If you do a Giemsa stain, you see a very, very characteristic bipolar bodies, safety pin bodies because of stain on the margin. How does the lesion appears? The lesion has a very red exuberant ulcer. Okay, clear? Chalo. Now coming to the next part, that is lymphogranuloma venereum, LGV. What is the causative lesion? For LGV, what is the causative lesion? Or what is the causative agent for lymphogranuloma venereum? Chlamydia trachomatis. L1, L2, L3. Clinically, no ulcer. Or sometimes you get a transient painless ulcer. Sometimes you get a transient painless ulcer. But what is troubling the patient? Painful lymph node enlargement, which is known as bubo. Now please remember students, in the patients of LGV, what happens? The chlamydia enters the lymphatics and causes lymphatic obstruction, giving rise to genital elephantiasis. So you can see here the male genital elephantiasis is known as saxophone penis or ram horn penis, while the female genitals, you can see there is swelling of the female genitalia with lot of deformity here. This is known as ichthyomene or vulvar elephantiasis. So if you get any of this picture, this is very classical of lymphogranuloma venereum. Okay, lymphogranuloma venereum. You have obstruction to the lymphatics giving rise to the following lesion. So that is LGV or lymphogranuloma venereum. Clear with this? Any confusion? So LGV, if you get a question, any of these features can be given. So with this, we are done with the genital ulcer ka 4 DDs. One is the syphilis, second is chancroid, third is donovanosis, and the fourth one is LGV. Now coming to urethritis. Please remember, urethritis due to STD, it is of two types: gonococcal and non-gonococcal urethritis. Gonococcal and non-gonococcal urethritis. So you have two types. One is gonococcal, another is non-gonococcal. In gonococcal urethritis, the causative agent is Neisseria gonorrhea. In non-gonococcal, you have multiple causes like ureaplasma, mycoplasma, trichomonas vaginalis, but the commonest is chlamydia trachomatis. The commonest is chlamydia trachomatis D2K. Now, how the patient present to you? Patient of urethritis will come to you with a history of unprotected sexual intercourse, and after the unprotected intercourse, he will give you a history of burning micturition. When you examine these patients, what will you observe? That you will see that there is some discharge coming out of the urethra. So history of unprotected intercourse followed by burning micturition and pus discharge per urethra indicates that you are dealing with urethritis patient. Now, very simple way to solve whether it is gonococcal or non-gonococcal. Please look at the incubation period. In gonococcal urethritis, the incubation period is usually less than a week. But for non-gonococcal, the incubation period is more than a week. Second is, you will do a gram stain. In gonococcal, the gram stain shows gram-negative diplococci, but in non-gonococcal, the gram stain will not show any organism. Also, it is difficult for us to culture the chlamydia. So very quickly, I am writing here that how to differentiate gonococcal from non-gonococcal. The incubation period is less than 1 week, while the incubation period is more than 2 weeks. On gram stain, you get gram negative diplococci. Please remember, important, this is a picture given. You can see the picture here, gram negative diplococci. But if you do gram stain for non-gonococcal, you see no organism. Why no organism? Because chlamydia is not visible under the gram stain. It is also difficult to culture. It is also difficult to culture. So please remember, for gonococcal and non-gonococcal urethritis, this is a very simple way to differentiate. Short incubation period, it is gonococcal. Long incubation period, most of the time it is chlamydia trachomatis. Understood this? Clear hai? Clear? So please remember, urethritis say we are getting continuous question. In general, if somebody asks you which is the most common type, it is gonococcal urethritis. Which is the most common type of urethritis after unprotected sexual intercourse? Please remember, gonococcal urethritis is the commonest cause. And if they ask you which is the most common type of non-gonococcal urethritis, it becomes chlamydia. There are many causes of non-gonococcal, but the commonest organism is chlamydia trachomatis. Okay, so with this we are done with the urethritis also. Now very quickly, if you have space somewhere, I would like to write down the STD kit also. So very quickly, STD kit, because we are getting frequent questions out of it. So in STD kit, please remember the kit number 1. It is for urethral discharge. And also remember cervical erosion. This was a recent question in NEET PG. If a female present to you with cervical erosion, the causative agent is either Neisseria gonorrhea or it is chlamydia trachomatis, and that is why we are treating a female of cervical erosion with kit number 1, which is a grey color kit. For kit number 2, we are using vaginal discharge. Only vaginal discharge, nothing is given, no history of cervical erosion. It is a green color kit. Kit number 3 is non-herpetic genital ulcer. Non-herpetic genital ulcer, which is a white color kit. Non-herpetic genital ulcer, white color kit. Kit number 4 is also non-herpetic genital ulcer. But who are these patients? These patients are those who are allergic to penicillin. And if we are, can you tell me, if a patient is allergic to penicillin and if you have to treat syphilis, what do you give? You give you give doxycycline, and that is present in your kit number 4, which is a blue color kit. Kit number 5 is herpetic genital ulcer. Now few students are asking me, ma'am, how does herpes present? Please remember, herpes also present like chancroid, painful ulcer, painful lymph node. Then how to differentiate? Please remember, in herpetic ulcer you will get lot of history of recurrence, history of vesicles. So that is something which give you a clue that you're dealing with herpes, history of recurrence, or they will give you history of vesicles. Okay, so that is a clue. I hope it is clear. Kit number 6 for pelvic inflammatory disease, it's a yellow color kit, and kit number 7 for bubo, the color is black. A simple mnemonic: gray girl wearing a bracelet, reading yellow book. So that is a trick to remember the color coding. So I think I will stand here, then it becomes easy for you to see. So kit number 1, it is urethral discharge, cervical erosion, gray. Kit number 2, you can remember 2 matlab V, it appears like V. So kit number 2, vaginal discharge. Kit number 3, non-herpetic genital ulcer. Kit number 4 is also non-herpetic, but what is the problem here? Here they are given for the patient who are allergic to penicillin. Kit number 3, herpetic genital ulcer. They will give you presence of recurrence or vesicles in the question. You have to give red color kit. For PID yellow, and for bubo it is black color kit. Okay. Now please give me a quick thumbs up if you are clear with this. We are done with STD. Just one thing, remember, whenever you have a patient of STD, you always treat the partners of the STD patient. But can you tell me what are the 3 STDs where the partner treatment is not required? Anybody can tell me in which condition the partner treatment is not required? Which STD you do not give partner treatment? So please write down somewhere here, there only, that partner treatment is not required in 3 type of STD. Partner treatment not required: bacterial vaginosis, herpes, candidiasis. Please remember, in these 3 we do not need to give partner treatment. BV for bacterial vaginosis, then you have herpes, and then you have candidiasis. So with this we are done with STD kit also. Okay, clear. Now coming to the next part, the next page, the next image. Can you tell me what does the next image shows? What does the next image shows? There is a swelling which is present on the scalp. What is that next image? It's a feature of tinea capitis. Frequently asked question. So please write down tinea capitis. What is tinea capitis? It is a dermatophyte infection. Dermatophyte infection. And the first image which you see here, it's an image of chirion. It is an inflammatory type of tinea capitis. How does the patient present? The clinical feature is you have painful swelling. Painful swelling of scalp. Lot of pain is associated. Painful swelling of the scalp. You have discharging sinuses. You have scarring alopecia. And they ask you in exam, what are the causative agent? So please write down, the causative agent is trichophyton verrucosum, trichophyton mentagrophyte. Trichophyton verrucosum, trichophyton mentagrophyte. Please remember, causative agent are asked, and that is why I have made a mnemonic, Kendra Vidya Mandir School. Just remember this mnemonic, Chirion, Kendra, verrucosum, trichophyton verrucosum, Vidya, Mandir School, mentagrophyte, KVM. So chirion is due to trichophyton verrucosum and trichophyton mentagrophyte. It is an inflammatory type of tinea. Understood this point? Can I go to the next part? Okay. Aisha, for STD kit, it is always better to first remember the kit number, the indication, the color, and then go to the name of the drug. Okay, so it should not be like that you're only remembering the name of the drug but you don't know where these kits are given. Understood this point? Chalo. Now coming to the next type of tinea capitis. There are two non-inflammatory tinea. One is known as grey patch. This is also known as ectothrix. Now if this is the hair, the spores of the fungus, they are present on the surface of the hair. So ectothrix type of fungus, this is known as grey patch, but the black dot is endothrix. What do you mean by endothrix? If this is your hair, the spores are present inside, the fungus is present inside the hair, and this make your hair very fragile. The hair break as soon as it comes out of the scalp, and this gives you a very classical black dot appearance. So there are two types of non-inflammatory fungus, grey patch, ectothrix, or black dot, which is endothrix. What is the causative agent? Please remember, for grey patch, Microsporum canis. For black dot, it is Trichophyton tonsurens and Trichophyton violaceum. And there's a mnemonic to remember, and that is black and white TV. Black and white TV is the mnemonic. Black and white TV is the mnemonic. So now, clear hai? Can I get a quick thumbs up from all of you? So we have discussed one inflammatory type, which is Kirion. Now I have discussed the two types of non-inflammatory, grey patch and black dot tinea. And you have one more type of tinea. I hope I have that picture. This is your inflammatory type of tinea. This is known as favus. What is favus? What is favus? You have yellow color, cup-shaped scale, known as Cutula. This is also inflammatory type. And if it is inflammatory type, it is associated with scarring. And what is the causative agent? Trichophyton schonleini. Trichophyton schonleini is the causative agent. Trichophyton schonleini is the causative agent. Now few students are asking me, ma'am, what is hair perforation test? So very quickly I'm telling you what is hair perforation test. Please listen to me, all of you. Hair perforation test, it is done to differentiate the colonies of Trichophyton mentagrophyte from Trichophyton rubrum. These are the two very common type of Trichophyton species. Now what you will do, imagine this is the colony of Trichophyton rubrum, this is the colony of Trichophyton mentagrophyte. Now what I will do, I will put one hair in rubrum colony, one hair in mentagrophyte colony. After some time, when I will examine that hair, I will see that the hair which was present in the mentagrophyte colony, it has lot of perforations in it. But the hair which was present in the rubrum colony, no perforation. This is known as hair perforation test, which is positive in Trichophyton mentagrophyte. Can I get a quick thumbs up from all of you if this is clear? Clear hai? Okay, so mentagrophyte has positive hair perforation test. Chalo. Now coming to the subcutaneous fungus. First is mycetoma, frequently asked question. So what is the triad of mycetoma? There is swelling of the affected part. You have discharging sinuses. You have swelling of the affected part, you have discharging sinuses, and through these sinuses, some sulfur granules comes out. So there is a very classical triad of swelling, discharging sinuses, and grain. There are two types of mycetoma. Eumycetoma, actinomycetoma. What is the difference? Eumycetoma is due to fungus. Actinomycetoma is bacterial. Eumycetoma is a slow growing and more deforming type, and the color of the grain here is black. But the color of the grain in actinomycetoma is yellow. So that is the difference between you and actino. There's one more name, botryoomycosis. When a patient develops mycetoma like lesion, but the causative agent is staphylococcus, you call this botryoomycosis. So please remember, you call it botryoomycosis. Remember these three names, the eumycetoma, the actinomycetoma and botryoomycosis. Please remember these three, they are very, very important. Okay? Chalo. Now coming to the second subcutaneous fungus, which is chromoblastomycosis. What is chromoblastomycosis? Chromoblastomycosis, it is a subcutaneous fungus due to Phyllophora verrucosa. The name of the fungus is Phyllophora verrucosa. Clinically, patient develop verrucous or cauliflower-like lesion. And one thing on which we get frequent question is, when you do the biopsy, you see brown color bodies. And can you tell me what you call these bodies? Very nice, I already got the answers. Copper penny, tell me all the names. Copper penny bodies, medullary bodies, sclerotic bodies. The image is given here. Okay? So copper penny bodies, medullary bodies and sclerotic body. This is your chromoblastomycosis. Thick verrucous plaque occurs on the surface of the lesion. Now the next is sporotrichosis. This is one more type of subcutaneous fungus. Sporotrichosis. What is the causative agent? Sporothrix shanki. Sporothrix shanki. Clinical feature is linear nodule or ulcer. And why do you get this linear pattern of arrangement? Anybody can tell me the answer? Because of lymphatic spread. What is this type of spread known as? Anybody? Sporotrichoid spread. This is known as sporotrichoid spread. Very nice. If you do a histopath, you get star-shaped asteroid bodies. You get a very classical star-shaped asteroid body. Recently, there was a question, what all species causes sporotrichoid spread? So, sporotrichoid spread. What all species spread through lymphatics? Nocardia, Mycobacterium marinum, and Sporothrix species. So please remember, these are the species which spread like Sporothrix, and they are Nocardia and Mycobacterium marinum. So these are some of the subcutaneous fungus which can be asked in your exams. Now moving to cutaneous tuberculosis. Now cutaneous tuberculosis. First is lupus vulgaris. Now please remember, cutaneous tuberculosis is of different type, and actually I would just like to make a diagram somewhere here. Please remember, lupus vulgaris, TB canker. Just a second. You can just draw it here. TB canker, tuberculosis verruca cutis, lupus vulgaris, and scrofuloderma. They are all cutaneous tuberculosis. What is the difference? How they manifest in a different way? The mode of entry and the CMI is different. How does Mycobacterium TB enters the skin in TB canker and TBVC? It comes from outside. For example, patient was walking barefoot, accidentally stepped on the sputum of a TB positive patient. So exogenous entry. If the immunity is poor, patient develops a multibacillary type of TB canker. And if it is good, patient develops a paucibacillary type of lesion, which is tuberculosis verruca cutis. For endogenous spread means from lungs it spread to the skin, or from lymph node it spread onto the skin. With good CMI, patient develops lupus vulgaris, and with poor CMI, patient develops scrofuloderma. Okay? So please remember, sometimes they ask you this in your exam, that TB canker is a multibacillary type, the verruca cutis is a paucibacillary, lupus vulgaris is also paucibacillary, while scrofuloderma is multi. And the reason is the different mode of entry and the different cell mediated immune system. Okay? Can I get a quick thumbs up if this is clear to all of you? Clear hai? Clear, very nice. So please remember, now we will discuss how is the description, what is the description. Okay, so very nice. I can see a lot of fire coming. So I hope this is clear to all of you. Now coming to the cutaneous description of lupus vulgaris as well as the tuberculosis verruca cutis. In lupus vulgaris, patient develops annular lesion or annular plaque with scarring in the center and active spreading periphery. What is the site? It is the extensors. And when you press the lesion with a glass slide, that when you perform a diascopy, you will get apple jelly nodules. When you press the lesion with the glass slide, you get apple jelly nodules. Next is tuberculosis verruca cutis, which is through exogenous spread, also known as anatomist wart. Clinically, patient presents with a cauliflower-like growth. You can see a very classical cauliflower-like growth. Okay, so you see a very classical cauliflower-like growth. So please remember, lupus vulgaris is a plaque, while tuberculosis verruca cutis, it has a thickened, verrucous, like a wart appearance. So these are the two type. Now coming to the next part, scrofuloderma. Scrofuloderma, how it occurs? Whenever you have infected lymph node, the skin overlying the lymph node get involved, and that is your scrofuloderma. So what is the common site? Mainly the lymph nodes of the neck are involved. So if you see here, secondary to skin overlying the infected lymph nodes. The most common site is neck. If somebody asks you what is the most common type of cutaneous TB, please remember it is lupus vulgaris. But if somebody asks you what is the most common type of cutaneous TB in children, it becomes scrofuloderma. There are three more names which you should know with respect to cutaneous tuberculosis. And what are these three more names? It is erythema induratum. It is lichen scrofulozorum and papulonecrotic TB. What are they? They are skin tuberculid. They are the hypersensitivity reaction. Hypersensitivity reactions. They are the hypersensitivity reaction. There is no bacilli in these skin lesions. So please remember, they are not true TB. They are just the hypersensitivity reaction of the TB to the TB bacilli which are present somewhere deep inside your body. That is known as tuberculate. So just remember these three names: erythema induratum, lichen scrofulozorum, and papulonecrotic TB. Clear? Which is most common? Most common is lupus vulgaris. But in children, the most common is scrofuloderma, which is present on the neck, secondary to the involvement of overlying lymph node. Okay, ji, clear? Now coming to the next part. Now we will discuss how does the cutaneous lesion of human papilloma virus appears, HPV infection. Coming to the discussion of human papilloma virus infection. HPV, human papilloma virus infection. What is tuberculid? What is tuberculid is, please remember, tuberculid is just the hypersensitivity reaction. For example, I'm just giving you an example. Somebody with lung TB. Now, some of the inflammatory cells from the lung enter the blood, and from the blood it enters your skin. Now what happens, it start producing some symptoms in your skin, and these symptoms which appears on your skin, it is known as tuberculid. They are not due to Mycobacterium tuberculosis per se. They are not directly due to MTB. They are due to the inflammatory cells, and that is why they are known as hypersensitivity reaction. They are just a hypersensitivity reaction to TB foci somewhere else. The second one is lichen scrofulozorum, and the third is papulonecrotic TB. Clear? Okay? Papulonecrotic tuberculosis. Now coming to what is the cause of cause of everything, lupus vulgaris, scrofuloderma, the TB canker, TBVC, the cause for everything is M. tuberculosis only, Mycobacterium TB only. Now coming to human papilloma virus, common wart, which is also known as verruca vulgaris. It has a very characteristic rough surface. So it's a solitary papule with rough surface. Solitary papule with a rough surface. The causative agent is HPV 2 and 5. The causative agent is 2 and 5. Second is plain wart, verruca plana. You see, solitary papule with plain surface, something like this, and the causative agent is HPV 3 and 10. So please remember these images because we get a lot of image based question. Human papilloma virus, it can cause lesions on the skin as well as on the genitals. On the skin, there are two types. One is common wart, which is known as verruca vulgaris. You can see the rough surface on their top. This is because of HPV 2 and 5. But second is verruca plana. You can see a very flat lesion. Now it is raised, but the surface is smooth. It is verruca plana, and this is the reason for verruca plana is HPV 3 and 10. So two type of wart, common as well as you have plain wart. The third is plantar wart. You must have seen sometimes on the undersurface of the foot, you tend to develop wart. The commonest confusion between the plantar wart is the corn, and how you differentiate between a common wart, a plantar wart, which is due to HPV 1. The commonest DD is corn. How to differentiate the corn? When you press on the corn, there is pain. Pairing in a wart, you see multiple black dot. Can you see here? This is your necrotic blood vessel. So please remember how to differentiate a plantar wart from a corn. If you press the corn from the top, it will cause a lot of pain. But there is no such pain with a viral wart. And second is, if you look carefully, if you see some black dot on the surface, this is also a feature of viral wart. Why? Because these black dots, they are nothing but the necrotic blood vessel. The black dots are necrotic blood vessel. Okay, clear? Okay, now coming to the next part, The fourth type of wart is filiform or digitate wart. They are like finger like projections. And what is the HPV? It is due to HPV2. So filiform wart is due to HPV2. You can see that they are like finger projecting out of your skin. Finger like projection coming out of your skin. There is one more type of viral wart, and that is known as genital wart or condyloma acuminata. The causative agent is HPV 6 and 11, and please remember they are low risk virus. Please remember they are low risk virus. The HPV 6 and 11, they are low risk virus. It means it will never cause, please remember, it will never cause malignancy. Cervical cancers are not seen with condyloma acuminata because the strain is HPV 6 and 11. Clear? Everybody clear with this? So with this we are done with the genital warts. Now few important pictures which you should know. Now there are two pictures. You can see there is a bluish discoloration unilaterally present on the face. This is your nevus of Ota. It is a bluish discoloration unilaterally on face associated with blue sclera. And what is nevus of Ito? It is a bluish discoloration unilaterally on scapular region. What is the reason? In both of them you have premature arrest of melanocyte in dermis. And what happened? These melanocytes, they start proliferating in the dermis. There is a premature proliferation, the premature arrest of melanocyte in the dermis. Normally what happens during embryogenesis, melanocyte migrate from the neural crest, enter the dermis, and it goes into the epidermis, stratum basale. But sometimes it remain arrested. It remain arrested in the dermis. It remains in the dermis and they start proliferating in the dermis. Whenever you have pigment in dermis, the appearance, the color of the lesion becomes blue. If it is present on the face unilaterally over the distribution of trigeminal nerve, nevus of Ota, and if it is present over the distribution of posterior supraclavicular nerve, that is shoulder, it becomes nevus of Ota. So please remember, we do get a lot of questions also. Okay? Now coming to the next part, there is one more condition where you have premature arrest of melanocyte, and this is your Mongolian spot. Where there are present Mongolian spots, they are present on the lumbosacral area. Here also you see premature arrest. But please remember, in Mongolian spot, with time what happens? The melanocytes disappear. They degenerate in the dermis, and that is why Mongolian spot, with age, the pigmentation reduces. But nevus of Ota and Ito, it remains like that throughout your life. Now some nutritional deficiencies which are important. What is that first image? Can you tell me? The first image, you can see presence of keratotic lesions, thickened lesions on the extensors, phrynoderma, also known as toad skin. What is the cause of toad skin? Please remember, fat soluble vitamin deficiency, mainly vitamin A. Second is essential fatty acid deficiency. Essential fatty acid deficiency. Can you tell me what image is this? This is a very classical image of pellagra, vitamin B3 deficiency. And what do you call this? You call this as Castle's necklace. What are the 5 Ds? Sorry, what are the 4 Ds? You have diarrhea, dermatitis, which is mainly on the photoexposed site, dementia, and death. So this is a patient of pellagra. What do you get in vitamin B2 deficiency? You get cheilitis. angular stomatitis. You get glossitis. And sometimes you get the seborrheic dermatitis like picture also. This is your vitamin B2, that is riboflavin deficiency. Vitamin B2 or riboflavin deficiency. Now coming to the cutaneous malignancy, just few points you need to know about cutaneous malignancy. This is your malignant melanoma. Uncontrolled proliferation of atypical melanocytes will give rise to malignant melanoma. 4 types of malignant melanoma. Superficial spreading type, which is the most common variety. Second is lentigo maligna type. Third is acral. Fourth is nodular. Rare and poor prognosis. We have a criteria which is known as ABCDE criteria. What is ABCDE criteria? The lesion becomes asymmetrical. Means if there is a benign lesion like this, where the left and the right side of the lesion is same. But what happens, sometimes one side grows more compared to the other side. So lesion becomes asymmetrical. The border becomes irregular. The color of the lesion changes. It becomes variegate, variable. The color becomes variable. Diameter increases more than 6 mm. And all these changes occurs suddenly. The evolution occurs sudden. This indicates that we are dealing with malignant melanoma. Please remember, what is this ABCDE criteria? Malignant melanoma most of the time occurs in a benign pigmentary lesion. When will you suspect that this benign lesion is getting converted into malignant? Please remember, whenever you see that the benign lesion is getting converted into malignant, there will be either change in the shape, symmetry, color, or the borders become irregular, and this criteria system is known as ABCDE criteria. Now, how to treat malignant melanoma? You have to do wide surgical excision. You have to do wide surgical excision, that is malignant melanoma. Next is basal cell carcinoma. So this is an image of basal cell carcinoma. Please remember, it is the most common cutaneous malignancy. It mainly occurs on the sun exposed site because sunlight is the common site, so it occurs mainly on the face. On the face, if you draw an imaginary line from angle of mouth to the tragus, if you draw an imaginary line from the angle of mouth to the tragus, BCC usually occurs above this line. So the common site is sun exposed area, especially the inner canthus of the eye. Please remember, it is a locally aggressive tumor. Do not metastatize. It do not metastatize. And there is a very characteristic clinical appearance known as rodent ulcer. Patient develop a nodule which ulcerate with rolled out beaded margins. With a very classical rolled out beaded margin. So please remember, basal cell carcinoma, first of all, it is present on the sun exposed areas. Basal cell carcinoma, it occurs on the sun exposed areas, that is on the face. If you draw an imaginary line from the angle of mouth to the tragus, it is present above this, usually here, inner canthus. So sun exposure is the most common trigger. Second, it's a locally aggressive. It will not go into the distant areas. Unlike other tumors, it will remain localized to that particular part. Third, if you see the clinical appearance, they are nodule which soon ulcerate to become a rolled out beaded ulcer, which is known as rodent ulcer. Now, how to treat this? Please remember, the treatment of choice is sequential removal. And you do a surgery which is known as microscopic Mohs surgery. Now what you do, you just remove the tumor very close to the margin. During the operation, you examine the margin. If you see tumor cells, you will go and remove little bit more of the margin. Now why you are doing this sequential removal? Because there is a very limited space. You cannot do a wide surgical excision on the lesions on the face because of the limited area. So please remember, the treatment of choice is microscopic Mohs surgery. There are two drugs which we give is Vismodegib and Sonidegib. These are the sonic hedgehog inhibitor. Sonic hedgehog inhibitor. So Vismodegib and Sonidegib, these are the two drugs which you have to do. Okay, clear? So this can be asked in your exam. Now coming to the next image, and that is acanthosis nigricans. What is acanthosis nigricans? You have velvety plaque which is hyperpigmented. They are present on flexures like axilla, neck, groin. So velvety hyperpigmented plaque present on axilla, groin. Now two types of acanthosis nigricans. One is benign. It is seen in young patient associated with metabolic syndrome. What do you mean by metabolic syndrome? Obesity, diabetes, hyperlipidemia. And there is something known as maligna, which is seen in elderly associated with gastric adenocarcinoma. Please remember, this is your NEET PG question, that acanthosis nigricans, if you see in a patient who is obese, who has hyperlipidemia, who has PCOD, so it means it's a benign type of acanthosis nigricans. While if you see in an elderly patient with gastric adenocarcinoma, this becomes the malignant variety and it is known as paraneoplastic dermatosis. Now coming to the last part, sonic hedgehog, Brushita sonic hedgehog pathway. For BCC, sonic hedgehog pathway. Now coming to this, can you tell me what is this image? This is an image of target lesion. And target lesion is seen in erythema multiforme. In erythema multiforme, the target lesion contains three circles. There is dusky center. Then the second is, there is edema. And the outermost is redness, erythema. So when you see three zones, this is known as erythema multiforme. Three zones, erythema multiforme. What is the cause of erythema multiforme? Infection, mainly herpes. Second is mycoplasma. And the third is, or second is drugs. Paracetamol, sulfa, etc. Even NSAID. So when you see three circles, you can see here in this image, the central one is a dusky center, necrotic center. Then there is a zone of edema and then there is a zone of redness. Whenever you see three lines, think of erythema multiforme. The commonest cause is infection and the second cause is drug. It can be NSAID also. It can be NSAID also. This is your erythema multiforme. Now, if you see only two ring, if there is no central edema zone, only dusky center and erythema zone of outermost, this is known as target-like lesion or targetoid lesion, and that is a feature of SJS and 10. So please remember, the feature of SJS and 10 is you get a target-like lesion or targetoid lesion. So what is the difference? There is a dusky center. You have a dusky center and there is a redness on the periphery. Erythema on the outermost. Erythema which is present on the outermost. In the patient of SJS, the targetoid lesions, they are present in less than 10% of body surface area. and in 10 patient, the targetoid lesions, they are present in more than 30% of body surface area. SJS 10 overlap when 10 to 30% of the body surface area is involved. Along with that of targetoid lesion, you get hemorrhagic crusting on the mucosa in both SJS 10. Along with the target lesion, you get hemorrhagic crusting in both SJS and 10. Okay? So please remember, there is SJS when the targetoid lesions are in less than 10%, 10 when the targetoid lesions are more than 30%, and SJS 10 overlap when you have 10 to 30%. Please remember, in both SJS and 10, you see involvement of mucosa, which is usually more than 2. You have crusting, you have erosions. So that is a feature of SJS and 10. What are the drugs? Many drugs. Most common is anti-epileptics. Then you have sulfur drugs, allopurinol. All these drugs can cause SJS and 10. Now there is one image recently asked in your exam. This is your congenital melanocytic nevi. Please remember, it is a pre-malignant condition and it can cause malignant melanoma. It is more than 20 centimeter, associated with hair. Okay, so it was recently asked in one of the exam, and that is why I thought of putting this image. This is your congenital melanocytic nevus, usually more than 20 centimeter, present since birth. Now when it is present since birth, you will not do anything. You will just ask the parent that look at this lesion. If they show any change in their shape, size and color, it means that it is now converting into malignant melanoma, and now it is a time when you have to remove this. So this is your congenital melanocytic nevi. Now some allergic contact dermatitis questions which can be asked. This is your hair dye allergy. And what is the allergen? Paraphenylene diamine. PPD, paraphenylene diamine. This was also one of the questions. Patient has applied the hair dye on the face. Then there is a lot of redness. There is dermatitis which is present on the other areas. Okay? Disha, involvement of mucosa is seen in both SJS and 10. Okay? Seen in both SJS and 10. Now what is this? Bindi adhesive. What is the allergen? PTBP. Para-toluene or para-tertiary. Para-tertiary butyl phenol. So in the bindi adhesive, there is an allergen which is known as para-tertiary butyl phenol. It causes allergy and can causes chemical leukoderma. Now there are few more. Cement, potassium dichromate, metal or artificial jewelry. It is nickel. And please remember, nickel is the most common cause of allergic contact dermatitis. Most common cause of allergic contact dermatitis. Then what is this plant? Parthenium plant. It causes phytodermatitis and the allergen is sesquiterpene lactone. Okay? It is Parthenium plant which causes sesquiterpene lactone. This is the allergen. Name of the allergen is sesquiterpene lactone, and you are right, it is known as the Congress grass. Now lastly, they ask you what test you do to diagnose the allergic contact dermatitis. What is that test which we do to diagnose allergic contact dermatitis? It is a patch test. It is the investigation of choice for allergic contact dermatitis. You remove the patch on day 2, 48 hour, and you read the patch on day 4, 96 hour. And please remember, it is based on type 4 hypersensitivity reaction. So these are some of the questions you can get in your exam. Please remember that the patch test, it is removed on day 2. There should not be any confusion. It should be removed on day 2 and you have to read it on day 4. So 48 and 96 hours. There is no 72 here. 48 पे you have to remove and 96 पे you have to read the patch. ठीक है? Clear? Nehal paraneoplastic dermatosis में we have done acanthosis nigricans, which is important, and if you want I can just very quickly write the other paraneoplastic conditions here very quickly. What are the other paraneoplastic conditions if you want? Erythema gyratum repens, lung cancer, necrolytic migratory erythema, glucagonoma, trypapalm, lung cancer, and sign of lesser trilate. Gastric cancer. Okay, so these are some of the paraneoplastic condition. Okay, this is the paraneoplastic condition. Anushka, pathology test is not very important for exam. Pathology test is actually done for the neutrophilic dermatosis, like for the patients with ulcerative colitis, they have pyoderma gangrenosum, Sweet syndrome. So what you do, you just insert a needle, and that needle causes some inflammation on the skin, causes some induration of the skin, that is known as pathology test. Okay, so any type of a hyper inflammatory conditions of the skin will have positive pathology test. How to treat eczema? Please remember, eczema, any type of eczema, the treatment of choice is first of all allergen, remove the allergen, and second is give steroid. If it is mild, you can give topical steroid. If it is severe, you can give the systemic corticosteroid. Metal allergen, metal, any metal, it is nickel, which is the allergen, whether it is the buckle of the belt, whether it is the strip of the wrist, or whether it is the watch or anything. Okay, so please remember that is the allergen. I think we are done with almost all the things. Last line is lesser trilate syndrome. Okay, one picture is left. I think all the pictures are done. I think this page is left. Okay, so thank you all of you. If you have understood, if anything is missed, don't worry. I will be uploading the exact this PDF. The annotated PDF will be attached, so you can go back and you can rewrite whatever part is missed. So thank you all of you. All the best to all my students. Please read whatever we have discussed. Try to do lot of PYQs also, because in PYQs you will get an idea about the PYTs. Although I have covered majority of them, but also do 5 to 10 years of dermatology previous year questions. So thank you all of you. Have a nice day and good day.